We'll start with our pediatric emergencies. All right, can everybody see that?
Yep.
Okay. So like we all know, children are not just tiny people. Okay, they're their own kind of beast. They're affected by multiple different things, anatomy-wise, physically, their emotional level, their mental capacity. It's all different. That being said, they have a different range of illnesses, trauma, things that affect them that may not necessarily affect us as much. Main thing we need to remember is they are literally not tiny people. They are specific children. Okay? They're terrified of us. They're terrified of pain. They don't like when they get hurt. So whenever we talk to them, whatever we do, we need to make sure we're always honest. Because that's kind of the approach we need to take. Different types of kids, different age ranges will require a different type of approach. Obviously, an infant's not going to be able to talk to you. They're not going to care necessarily that we're looking at them. But a 3-year-old will not want us to come near them. Okay, we're like a doctor. What do doctors do? They give them shots. They don't like it. We have to change our approach depending on the age of the child. So infant-wise, children, very small children, most of the information we're going to get is from the caregivers, okay? We're also going to have to communicate with them. They're probably stressed out. You know, nobody wants a child hurt. Nobody likes when a child is sick. Number one concern, besides the child, is keeping that parent calm, because these kids will feed off their parents. If they're panicking, the child's going to be worked up. We're not going to be able to take care of them. We're not going to be able to effectively treat their symptoms. At the same time, if you've ever been around kids, you know it is chaos. Sometimes it's difficult to deal with them. We have to be able to remain calm. We have to be able to handle those situations, but be sensitive at the same time. So there's a couple different age ranges and classifications for it. They go through all kinds of changes during this. You know, you have infancy from your first year of life. Not much about that, okay? We pee, poop, and sleep and eat. That's about it. Most of the complications are solved with oxygen. All the information you get for those patients will come from the caregivers. Toddlers are starting to get out there. They're exploring their environment. They're going to be a little bit braver. They're also going to be hesitant to get away from mom and dad. You know, they'll have separation anxiety if we try to talk to them. We need to be aware of that. Be aware that they're not going to want us to take a blood pressure. So anytime you talk to these kids, make sure we're not using something to that effect. We don't take stuff from them. They won't want to give it to us. Preschool age, 3 to 6, same thing. They're starting to grow. They're starting to get taller. They're getting bigger. And with that comes more bravery. They're going to have more traumatic injuries from getting out there and climbing on stuff. 6 to 12, they're now in school. Okay, there's going to be a whole lot of social issues, emotional issues that go with that. You need to be aware that things they talk about, they may not want to talk about in front of their family or in front of their parents. And that continues on into adolescence, 13 to 18 range. That's when they're closest to us, to normal adult patients. So it's always a good idea just to kind of go through and take a look at the comprehensive PowerPoint. I know I said this one has 198. That one has 280 slides for this lecture. That'll go into a little bit more in depth about the age ranges, some of the stuff you encounter. the infant. So the first month after birth is what is a true neonate. Okay. After that, once they hit that milestone in 2 months, they're sleeping, they're eating, they're peeing and pooping. That is it. They don't have that object permanence yet. The only thing they can do is cry. That's how they get what they need. If they're hungry, they cry. If they need to be changed, they cry. If they need to sleep, they're going to cry. If we cannot get them calm, or after addressing those certain issues, they are still crying, that's a sign of something wrong. That's a sign where they may be sick or they may have had some kind of injury. 2 to 6 months, again, that persistent crying, not being able to console them, lack of eye contact, they're going to start tracking people now. If they're not, they may have a mental status issue. They may have delayed development. With that, we want to ask the family, the parents, the caregivers, what kind of medical history was. Was their pregnancy normal? Did everything come out normal? Did they happen to drink during their pregnancy? Anything that can lead us into figuring out what could be wrong with them. 6 to 12 months, we're getting bigger, probably taking our steps, starting to walk. They may cry if we separate them from their caregivers. A lot of times we can get information and do a good assessment while they are in their parents' arms. That being said, if we take them away from their parents and they don't react, that could be a pretty big indicator of a serious illness. So there's what our assessment looks like. Obviously, same thing when we look at it. Primary impression, the general impression when we see them from a distance. What do they look like? Are they moving around? Are they active for their age range? Are they crying? Are they not crying? Are they pink? Are they blue? All that information we can get before we even actually put hands on the patient. We don't want to really do anything painful at the end of these assessments. We don't want to poke or prod them at the end, because we want them to be calm. We want them to be kind of at their normal, if we're able to get there. And again, parents, especially if they're new parents, are not going to understand what we're doing. They're not going to know what's going on. They're going to be panicking. We need to explain everything we're doing. Okay, well, I'm touching his feet to try and figure out if anything's wrong. I'm pressing on his belly to see if it's tight or if it's hard. Explain this stuff to them. That way they're going to understand a little bit more. All right, good old toddlers. If you've ever had toddlers before, they're awful. Okay. They're growing up fast. They're running all over the place. They are a ticking time bomb for trouble. Okay. For one, the main way kids initially start exploring their environment is with their mouth. Okay. They stick stuff in their mouth all the time. So we have to be aware of choking hazards. For one, they don't have all their teeth yet. They can't chew that food appropriately. When they get a little bit older, into that 18 to 24 month range, they may have a specific toy they like, or a favorite blanket. When we're doing these assessments, or when they're ill, try and use that to our advantage. Let them have that while we assess them, or talk to them, or talk to the family. If we're going to put them on the stretcher, if we're going to put oxygen on them, let them have that blanket, that small amount of comfort. That way we don't cause any further issues. Just like with adult patients, we don't want to complicate matters by increasing heart rate unnecessarily or making them breathe faster because they're agitated. Same thing with these kids. Most toddlers do not like strangers. Obviously, they've spent time with their family and that's it. They probably will not want you to take them away from mom or dad. That's okay. Again, use that to our advantage. Let the parents help us. Okay. That you can't necessarily ask these kids, hey, does this is this a burning sensation, or can you tell me how this hurts? All they're going to tell you is, ow, it hurts. They don't know crushing, burning, stabbing, throbbing pain. They just know that it hurts and they don't like it. They also have an incredibly short attention span. Okay? These kids can go from trying to look at you and talk to you to looking at the ball that's over on the floor or the dog that's behind you. So just be aware that it's going to be kind of a task to get a good assessment on them. And we always want to start with the feet when we're assessing them. Okay? Because, again, these kids are used to their parents. They're not used to these big people in uniforms and flashing lights coming in with all the equipment we have and gloves on and trying to touch them. We start at their feet, it kind of lets us build a little bit of trust. We're able to work our way up to their head. And then again, like infants, if they're constantly crying, if they cannot be calmed down, no matter what the parents are doing, we're doing, anybody is doing, that probably means something serious is going on, whether that's a bone break or a severe illness, pneumonia. Just be aware that constantly crying, just like for adults, is not normal. So when we move into the preschool age, choking's still a risk. Okay, they still put stuff in their mouth, not near as much, but again, that trachea is narrow. Okay, their airway is much more narrow than ours is. So anything that they put in there could potentially get lodged and cause them to either aspirate or asphyxiate. The good thing about this is we can talk to these kids most of the time. They can tell you more stuff. They can't tell you exactly, hey, have you ever had anything wrong with you before? Well, I tripped and skinned my knee. They're not going to be able to tell you, yeah, he had RSV as a baby. Family's still going to be the best part for that. When you're talking to these kids, don't give them the runaround. Don't use big words. Just tell them, do you hurt here? Or where do you hurt? When did you get hurt? Things like that. Give them short questions that they can answer fairly quickly and with a simple answer. Okay, they're not wordsmiths. They're not going to know all the big words that we do. We got to get down to their level. If any of you guys have ever had imaginary friends, use that to your advantage with these kids, right? They may say, well, Frank here pushed me down and I hurt my knee. Okay, well, when did Frank do that? Use their imagination and let it help you talk to them. But don't ever lie to them about anything that we do. Don't ever tell them this, if you're fixing to give them an epi shot or anything like that, don't ever tell them, well, this isn't going to hurt. Okay, because once you lie to them, guess what? They're never going to trust you again. So always be honest. If it hurts, tell them, well, this is going to hurt for a minute, but after that, it's going to help you feel better. They can get distracted pretty easy, just like the previous age bracket. Especially if we're fixing to give them medications, distract them, okay? We can tell them this is going to hurt for a second, but then give them, a ball or a toy to play with for a minute. Same thing with the feet. We really don't want to start looking at the head first until they get a little bit older. We're still trying to build trust with these kids. Use Band-Aids all the time. If you give them a shot or if they have a scratch, give them a Band-Aid. They will love you, right? You have fixed part of their boo-boo. Like it says, they're starting to learn that their bodies are different. that there's a reason why we all wear clothes. Again, just like anybody else, keep them covered as much as possible. Yes, we have to assess injuries, but if we can avoid completely depantsing these kids, great. We want to give them their dignity just like we would want our own. 6 to 12. Okay, they do understand death. They know that people do disappear. They do not live anymore. Okay, grandpa died. They understand that. They may not understand why or how necessarily, but they do have that concept. We're starting to move now into where we can ask the good questions and get good answers from them. Our assessment, instead of being more pediatric focused, is getting closer to that adult assessment we've been doing this whole time. At this point, we're able to talk to the kids just as much as we talk to the adults. They're starting to get more independent. They want to talk. So instead of just only asking mom and dad anything about them, especially if it's related to pain, ask the kids. Let them be a part of the treatment. For one, that helps earn trust. At this point, they've been to the doctor plenty of times. They probably know what a physical exam is. They probably understand when you say, hey, I'm going to go ahead and touch your belly because you're hurting there. Tell me if this hurts. They'll know what that is. They'll expect what's to come. And this is where we can finally start there with the head. We don't have to start at the feet when we're doing the assessment. If we can, give them choices. Does this hurt like it's on fire, or does this hurt like you were punched? Things like that. We don't usually want to give those kind of closed-ended questions, but with children, their concept of pain is still limited. Just make sure that you're controlling answers, because if you ask them certain questions, they will take off into left field and give you something you don't even completely understand. They may start talking again about their imagination, and then now we don't know what we were even asking in the first place. But just like asking them questions, let them be a part of the process. If they want to say, hey, what's that? Can I listen to? Let them listen to their lungs. Let them listen to their heartbeat. Make this process less scary. They're already scared. They're already hurting. Try to make it easier on them. They understand the difference between being hurt physically and being hurt emotionally. Okay, they know what makes them sad versus what is painful. Same thing when we explain to adults how things work or what we're going to do. We're going to explain it to them. We're just going to have to use simpler terms and probably shorter sentences. Not necessarily going to say, well, I'm going to take your blood pressure right now. I'm going to say, well, this is going to give your arm a hug and let me see how strong you are. Something they can associate it with. Ask the parents for help. Hey, what's the best way to talk to them? Is this normal? They'll be able to give you this information, especially if they have certain conditions, autism, Down syndrome, things that may have an assessment, I guess roadblock would be a good word for it. But family will know how to talk to them, and they'll be your best guide to getting the answers you need. Good old adolescents, teenagers. Teenagers are like adults, but whether they want to admit it or not, they're still kids. Emotionally, they don't have the emotional maturity that most adults should. That being said, what happens when we were all teenagers? We thought we were invincible. We thought we could do whatever we wanted and we weren't going to get hurt. So they take a lot of risks. They do things that most people would say, that's probably pretty dangerous. So we have to be prepared for fairly significant trauma with these types of children. This is really where our assessment moves into the adult assessment. They're able to answer the questions. They're able to talk to us, right? They're able to understand these treatment options that we're doing, or the theories and thoughts behind it. They'll be active participants in their own care. They don't want to hurt. They're probably going to help you to help them. And at this point, it's the same as when we talked about assaults and things in the last class, where we ideally want to have somebody of the same gender assess and do a physical exam on these kids. (13 to 18), we're going through puberty. We're having those changes. Female patients could possibly be pregnant. So again, like before, like last class, if they have abdominal pain, guess what? It's an ectopic pregnancy until we can prove otherwise. We're still going to ask them all the questions. We're still going to give them the open-ended questions now. Okay, they can answer them correctly. Hey, describe how this hurts, or tell me exactly what happened. They can answer those. They also understand pain way more than other school-age kids. All right, I'm going to go through a little A&P for children. Like I said, it's wildly different. Okay, they are not just tiny adults. Their anatomy does have significant changes that can affect possibly life or death for these kids. So looking at that picture, we can see, for one, their tongue is rather large. Their airway is shorter, and it's a lot more narrow. If you look, you can see that the lungs are quite a bit smaller. Okay, they're still growing, so they have to breathe a little bit faster than we do. Their heart sits a little bit higher in the chest at this point because everything has not fully developed. They're getting taller. Eventually, they will get to the point where their heart sits where ours does. In that glottic opening, you said it's higher. That's why we run into epiglottitis a little bit more with kids, because it's significantly larger. But as they develop, like it says, their vocal cords, epiglottis, eventually position themselves in the correct position for when they're an adult. Usually between 13 to 20 is when everything is kind of definitively okay. Now they're adult proportioned. So, anatomy of the airway, they got a bigger head. Okay, the back of their head is rather large. So that makes it a little bit more difficult, especially when we're trying to put them in a neutral position for airway, or we're trying to do head tilt, chin lift, anything like that. That head is quite a bit of a problem. The tongue is a lot larger. Okay, it's going to get in the way more often. It'll block the airway more so than it would in adults. Everything besides the trachea is pretty much larger. Epiglottis, all that stuff is larger while we have a more narrow airway. So that's why most of the time we have respiratory problems with kids. So if you look right there, it says the diameter of the trachea is about the same as a drinking straw. So not very big at all. So when we talk about respiratory emergencies in kids here in a minute, when we have that swelling of the airway, that straw will close up fairly quick. So like we said, their lungs are smaller, their airway shorter, they're having to breathe faster, they have twice as much oxygen demand. Okay, their muscles are not as well defined. Their stomachs are a little bit more difficult to deal with because they're breathing so much. They have a lot of times they'll get gastric distension. It won't let them move that diaphragm. They won't be able to breathe as fast anymore. Their skin is a little bit thinner and their chest muscles haven't developed as much, so you're going to be able to hear those breath sounds a lot better. If you've been on clinicals and you've listened to breath sounds so far, just as soon as you can listen to a kid, try to, and you'll notice a significant difference. It does make it harder when we're trying to figure out if they have decreased movement, air movement, or if they have decreased breath sounds, because all that stuff is transmitted. So the circulatory system, we want to know what is a good heart rate, okay? Because like we said before, in some emergencies, the first sign of shock is an increased heart rate. Well, kids' heart rates are faster than ours. Infant heart rates, 160 or more. They will compensate far better than we will for a longer time. They close off all their blood vessels in their skin, like their hands, to protect the core organs. Same thing like we do. They just are able to, I guess, withstand that a little bit longer than we are. Easiest way I can tell you is they'll last quite a bit, and then all of a sudden they will take a huge nosedive into the toilet. So there's your heart rates. Like I said, newborns, 3 months, 85 to 205. It's fairly fast. It doesn't start slowing down really until we get to 2 years old. And eventually by the time they're 10, it should be fairly well the adult normal rate of 60. So when we talk about the nervous system, we know that's what controls movements, sensation, pretty much everything, right? It's not as developed, it's not as protected. Like most of us know, kids got big heads and little bitty bodies. They're top heavy. So when they fall, the number one thing they strike is their head. We have to be prepared for significant head trauma anytime we hear of a fall involving a pediatric patient. That subarachnoid space is smaller, so they don't have that cushioning for their brain. And that leads to more significant damage. Now we know the brain is kind of a glass jaw. It's not very well protected in the first place. It's kind of weak. So it is prone to having brain bleeds from shearing forces. And we know shearing is that kind of cross motion. So just like everything else, they require more. Okay, the brain requires more blood flow, more oxygen, more sugar. It's running faster. It's developing. It's taking in more energy. They run the risk of having more severe brain damage from low blood pressure or hypoxia than we would. So anytime we notice that they are turning blue, we have to be quick. We have to get on it incredibly fast. The good thing is spinal cord injuries are less common, just because bones are still a little bit more pliable. They're able to kind of bend and move just a little bit. They're going to injure those ligaments more often. At the same time, what happens when they complain of neck pain? Well, we still do C-spine, we still do stabilization. It all just depends on your local protocols and what kind of equipment you have. Our X collars go down fairly small, but it doesn't go small enough for some kids. So if that happens, either you use a pediatric collar or if all else fails, towel rolls, making sure we secure that head the best we can. Talking about the GI system, just like everything else, it's not as developed yet. It's still growing. We don't have the fat stores in their body like some of us do already. So they're not as protected from trauma. So when they get hit by something or they have some blunt force trauma, it affects those organs in there far more. Because we know how big the liver is in our bodies. You know, it takes up almost the entire upper portion of that quadrant. Imagine what a child's liver looks like. Their spleen, their kidneys, they're a lot closer to one another. So when we have that damage, not only do we run the risk of a lacerated liver, but it could have a ruptured spleen or kidney damage. So whenever we have these significant traumas, mechanisms of injury, we always have to have that high index of suspicion that this is going to go bad very quickly. Skeleton-wise, they are growing like weeds, right? It seems like every day you look, they're getting taller, they're getting bigger. It's because of those growth plates at the end of their bones. They're flexible, but they can have stress fractures. Anytime we see a patient complaining of, leg pain, arm pain, take a look at the length of their arms versus the other one. You can usually figure out if they actually have an injury or growth plate injury from that. When we talk about infants, their skull is not fused quite yet. So those bones are still kind of soft. They're able to move a little bit more, so they run a far bigger risk of having brain damage than, say, a 3-year-old or a 6-year-old. And in that thoracic cage or ribs, they're a lot more pliable. So instead of having, broken ribs, they may have a busted lung or, a tamponade or liver damage. The ribs don't necessarily protect anything very well at this point. So then, I can't ever say this word right. The integumentary system. Well, our skin, it's thin. We don't have near as much fat, right? They're building up fat stores now. So their temperature regulation kind of stinks. They also have a lot more surface area. So when we get burns on these patients, they're a lot more significant. It goes down deeper because of that lack of fat and that thin skin. And they're going to lose heat that much faster. So just be aware when we get burn patients, especially kids, we've got to get them cooled off and stop the burning, and then we got to get them covered up. All right, so scene size up. Again, starts with our dispatching information. If they tell us it's an infant or it's a child, at least we'll know, okay, I'm not going to be able to ask most of the questions I normally get to ask. You start adjusting kind of what equipment you're going to take in, what type of questions you'll be asking, how you're going to do your physical assessment in the first place. If you can, get all that information that it says, the age, gender, location, nature of illness, mechanism of injury. If we can get that from dispatch, that makes things just that much easier so we can start forming that impression of what may be wrong. Scene safety is pretty much the same thing as before. Make sure that you're safe yourself. There's no danger in the area. Make sure they don't have any kind of infectious diseases. Environmental assessment, is it a normal house? Is it, in Texas heat and they don't have an air conditioner, or is it the middle of winter and there's no heater? Things like that to help clue you in on, okay, this may be an exposure problem. Is the house well kept? Does it look like there's dirty needles lying around? Just kind of keep your eyes open for anything that might help you figure out what may be wrong. So what happens when the kid can't talk to us or they're too young? Well, you got to assume it was bad enough that they've got some kind of head or neck trauma. We're going to go ahead and immobilize them, right? C-spine, towel rolls, whatever we need to. But we'll use the pediatric assessment triangle to do most of this assessment. Pretty much determines sick, not sick. So, work of breathing, their appearance, circulation of the skin. Realistically, that looks like ABCs, right? And that's what it is. It's just focused more on pediatrics than anything. We should be able to do this within 30 seconds or less. Just getting eyes on the patient, you should be able to see, okay, well, they don't have any obvious bleeding. They are breathing. It just looks a little fast, and they look like they're looking around. Your primary assessment, your general impression is done right there. Just like our regular general impression, this kind of tells us whether we get to kind of sit around and do a little bit more thorough assessment, or if we need to go ahead and move them to the truck and begin transport. If they are unstable, like it says, ABCs, make sure everything's intact. Any obvious life threats? No. Okay, transport. We do everything else on the way. If they're stable, then you do your primary assessment and then your secondary assessments in the truck. So hands-on ABCs, okay? We're not just kind of looking at them saying, oh yeah, their airway's open. We're actually going to actively kind of manipulate their airway if we need to. We're going to make sure that these things are intact before we continue on. So if it's open, again, we're making sure it works right. Great, their airway's open. Are they actually breathing? Do we have air coming in and out? If we can't get any response out of them, or if it looks like it's difficult to keep open, if they keep their head tilted down or they're unconscious, we need to make sure that there's nothing in there before we continue on. Okay, pull your suction out, suction any blood, anything out of there. As it says, the sniffing position. So their head's slightly extended, kind of like they're sniffing in the air. That is the neutral position for children. That way it opens up that airway. And at that point, if we're having to do that and still maintain it, most of the time we need to go ahead and manage their airway, whether that's with a NPA or OPA. We want to make sure that they're going to continue breathing while we're there. So look, listen, feel. Okay, we're going to look at them, see if their chest is rising and falling. We're going to listen to their lung sounds if we can, and then we're going to feel. We're going to put our hands on their chest to see if it's moving. God, that's loud. Infants will belly breathe, so if you see their belly moving in and out, that's okay. That's not anything out of the ordinary for infants. But with kids, like we said, their heart rates usually increase, so is their respiratory rate. Their lungs are smaller, like we've talked about. They need more oxygen, twice as much as we do. So when they start breathing less and less, we need to be prepared that if we don't fix this now, they're going to stop breathing completely. Because most of the time with kids, the number one cause of cardiac arrest is respiratory. Circulation, same thing. We're going to check for a pulse. Okay. Is there any obvious bleeding? Infants, obviously, we're not going to be able to get a radial, right? We use a brachial or the femoral pulse. Anybody older than 1 year old, you can probably get the carotid off of them. If they've got a good, strong pulse, more often than not, they're not going to be hypotensive. Okay, but if it's weak or if you can't feel it at the brachial, that's a bad sign. That's usually a late sign of shock for these kids. Again, increased heart rate, tachycardia, it's going to be your first indication that something's wrong. Most of the time we can correct that with oxygen. And it's not something we're going to do just once. We're going to continuously monitor the heart rate. Okay. Most of the time it's going to be every 5 minutes, just like every other assessment. But we're going to keep an eye on it. We're going to check their skin, make sure it's normal, make sure it's the right temperature, make sure it's not extremely dry or soaking wet. And then we want to try and get a cap refill. So a cap refill, what you're going to do is, especially on an infant, you can just press down on the bottom of their feet and watch how long it takes to have that color return. Pretty much everybody should have color return within less than 3 seconds. If it's anything longer than that, we probably have some kind of shock going on. They have hypoxia, whether we can see it with any other symptoms or not. So disability, that's usually how we're going to assess mental status. AVPU is going to be your best one. You know, are they alert? Do they respond to verbal stimuli? Is it painful stimuli, or are they unresponsive? Check their pupil response. They may have gotten into something that decreased their mental status. They may have pinpoint pupils. You know, if that's the case, then they had a possible opioid overdose. Make sure their body parts are moving correctly, and if they're moving at the same time, especially in infants. Again, if you startle an infant, most of the time they're going to pull their hands and legs up. You know, they should do that at the same time. Looking at that is a good indicator to see if there's maybe a brain injury or any kind of traumatic event that happened. Obviously, pain is present with most injuries. Pain is part of an injury. So that should be fairly obvious. The way we ask about pain, again, is going to depend on how old this patient is. If they're, you know, a teenager, we can ask them the same way we ask adults. If they're 3 years old, we're not going to get that detailed answer. So exposure, temperature-wise, doing that hands-on ABCs will kind of help you figure that out, because you'll be assessing their skin temperature. You know, if they're running a fever, they're going to be hot. We know that. That being said, these kids don't have very good temperature regulation starting out. Again, they have a lot of body surface area. They don't have a lot of fat storage yet. So they're prone to getting that hypothermia. Ideally, put a blanket on them, turn the truck heater on, keep them warm. Okay, same thing that we do when we have shock patients. We want to keep these people warm. Transport decision, same thing like we do with any other patient. We decide, you know, is it load and go or stay and play? If they've had some kind of significant mechanism of injury, nature of illness, if there's some kind of abnormality, significant pain, if they're unresponsive, all those are good indicators to go now. And we need to ideally take them to the appropriate facility. But if they are truly in trouble and they are going down the drain, you always start with the closest facility. Okay. If they're less than 40 pounds, we need to put them in a car seat that can be mounted to the stretcher. All of our ambulances carry car seats in there. We also have the PD mate for younger kids. Utilize them. If we need to secure a car seat to the captain's chair, we can. I would prefer it to be on the stretcher. At the same time, we don't want to necessarily use the patients, especially if they've been in a car wreck. We don't want them using their car seat because it could have been compromised in it. So if we got them C-spined, we're going to keep them on a longboard if we need to. Whatever's going to keep their spine stable. Obviously, if they're in cardiac arrest, we need to have them secured to the stretcher somehow. If that's a backboard, that's a backboard. If it's the stretcher, it's the stretcher. We just talked about using their own car seat. Preferably not, like I said, especially if we think it's been damaged. Because the goal is to get these kids to the hospital safe so that they can fix them. Just like our other emergencies we talked about, we're not necessarily fixing the cause. We're taking care of symptoms until we can get there and let somebody else give them that definitive care. So history taking, we've already kind of touched on this. It depends on the age of the patient. Obviously, if they're a young kid, they're not going to be able to tell us their history. They probably don't even know what medical history is. That will have to be gotten from either the parents, the school nurse, paperwork, whatever adult knows that patient. Teenagers, we can get it from them. Most of them know enough about their body and about their problems that they can tell you. And again, we're focused on that chief complaint. Remember, the chief complaint is what the patient themselves is complaining about. Or in this case, it could be what the parent is complaining about if the patient does not understand that concept. So we should kind of base those questions around that specific problem. Same thing like some of our other questions that we've been going over for primary assessments and history. Obviously, we want to know the nature of illness, mechanism of injury, what happened, how long it's been going on for, what were you doing when this happened, do you have a fever or have they had a fever? That's always a good question to ask when we think they're ill. Are they normal? Do they normally act this way? Is this out of the ordinary? Are they more active than this? All good things to ask about. Eating, drinking, and output. We need to know how many diapers they may have soiled. Have they peed through, only 2 diapers in the last 2 days? That's a significant problem. At the same time, if they've had, diarrhea for 4 days straight and they're a 6-month-old, that's significant. We need all this information so that we can kind of form a treatment plan to the best of our ability. And some more additional questions: vomiting, diarrhea, abdominal pain, all good things to know. Do they have a rash? Could this have been some kind of illness, or was it a exposure to something? Most of the time we want to take the caregiver with us. Again, for one, that makes it easier on us. It keeps the patient calm. But sometimes it's not that way. Sometimes they have to take their own vehicle just in case they get discharged. We understand that. We need to make sure we've got their name and their phone number. Okay, because they're going to be required at the hospital to be able to treat that kid. So always make sure you get that information if they're not coming with you. Realistically, they're going to want to come with you. Most parents do not want to leave their children with you. Sample history, OPQRST, it's the same as it is for adults. Again, the questions just kind of change based on the age of the kid. Okay, we want to get that information, but we have to ask it the right way, in a way that they can understand us. Secondary assessment, a lot of the same stuff. Again, we're going to use that DCAT BTLS, especially if they're unresponsive. We want to see if there's any additional injuries or problems that we haven't found yet. If we know it's a specific injury or a specific illness, focus on that. That's what that secondary assessment is for. Again, like we said, starting at the feet for everybody up to 6 years old. That way we don't kind of freak them out. And then after that, anybody older than 6, you can start at the head. So there's physical exam, head, nose, ears, mouth, neck, eyes. We're looking at all that. Okay, we need to see if there's any kind of abnormalities, anything that may clue us in onto what's going on. Chest, back, abdomen, extremities, the rest of the body, right? That's what we're looking at. Blood pressure is kind of hard to get in kids younger than 3. We do have blood pressure cuffs like that for our cardiac monitors. You may not be able to hear that as a manual. For one, kids don't like when we squeeze their arm. We have to try and keep them calm with that. That being said, the easiest way to figure out if they have a good blood pressure or if they're hemodynamically stable is that circulation. Do they have a good pulse? Is their capillary refill within 3 seconds? Most time, if you get that, that's always going to be your best indicator. And like it says there, we want to make sure we use the right equipment. Like I said, we have small enough cuffs down to infants, but ideally that cuff needs to cover 2/3 of the patient's upper arm. That way we can get an accurate reading. So if you're trying to figure out their blood pressure, for anybody up to 10, 2 times their age plus 70. That is the very minimum blood pressure that they need to have systolic. So if they're 10 years old, 2 times 10, we got 20 plus 70, 90. That's what their blood pressure at a minimum should be. The respiratory rates, it depends on the kid. If you sat there and tried to count respirations for 60 seconds, it's hard. Especially if this kid is excited or panicked, you're going to be breathing fast. Try to count for 30 seconds and then just double it. In infants, again, they're belly breathing. So we're going to be looking at that belly, seeing how many times it moves. Pulse-wise, brachial's really good, especially on younger kids. Grab a brachial, take your watch out, count it for a minute. Take a look at their eyes, make sure their eyes are working correctly. Use pulse ox, whatever you have available. If it will benefit you in helping learn what the vitals are for your patient and whether or not they are stable, use it to your advantage. Again, reassessment, we've talked about that before quite a bit. 5 minutes if they're unstable, 15 if they're stable. Anytime you do a new assessment, anytime you do a new intervention, anytime something changes, you will always reassess them. Intervention-wise, so unfortunately for pediatrics, a lot of stuff we can't do EMT-wise. We can give oxygen, we can help with inhalers, we can give EpiPens or assist with giving EpiPens. That's about it, right? But we can get the parents to help us with it too. Okay, because parents may have already had to do this once or twice. They may understand that. Again, communication, documentation. Always give a good hospital report. Always let them know exactly what's going on. If you found anything pertinent that they need to know about, we want them to know as much about that patient before we get there as possible. That way they already have a treatment plan thought of so that this kid doesn't have a delay in definitive care. Does anybody need a break or anything? And y'all still good to go?
I'm good.
Okay, we're like maybe a quarter of the way through this lecture, and that's already. So. All right, respiratory problems. Like I said, cardiac arrest. The #1 cause is respiratory. If we cannot figure out that this is their problem, if we don't treat it right away, they will die. They have to work harder anyway to breathe. Like I said, their airway's smaller, their lungs are smaller. They work harder, they breathe faster. So if they go into failure, they're not coming back. Take a look at them. If they're starting to get tired, if they're slowing down, if they're getting anxious, if they're fighting you, that may be a sign that they're not getting enough oxygen to support their mental status. Signs and symptoms of increased work of breathing. We already know this from our previous respiratory emergencies. They're going to have those intercostal retractions. They're going to have that increased abdominal breathing, nasal flaring. We need to look for all those kinds of things. Cyanosis. They're going to turn blue around the nose, the lips, the fingers. Always look for that stuff early on. That way we can catch it before it gets worse. So if we don't catch it, and if it just continues and continues, eventually they'll have kind of small periods where they'll just stop breathing because they just can't anymore. Their body will need to catch up. That causes their heart to be deprived of oxygen, and then eventually it's all going to stop. But like it says, respiratory failure doesn't necessarily mean that they have an obstructed airway. It may be just that they're severely dehydrated and they're not getting enough blood flow to the brain to keep them breathing. Or they may have had some kind of trauma that's damaged their chest. So if it's a failure, we're fixing to have to breathe for them. Just be aware it's not necessarily because they choked on something. So again, like we talked before a while back, respiratory distress, respiratory failure. Failure means we've had to actively participate in the breathing of that patient. Going from respiratory distress to failure can happen in an instant. The majority of the time, these kids are going to need extra oxygen. Go ahead and put them on a non-rebreather at 15 liters to give them that 100% or that 90%. If we need to breathe for them, breathe for them. Don't hang back hoping that we're not going to have to do that, because then we will. I don't necessarily want to say be super aggressive about it, but be aggressive. If they need that oxygen, give it to them. Airway obstruction, like I said, kids early on, they learn their environment through their mouth. So they put stuff in there that shouldn't go. Sometimes it can get stuck. At the same time, we said that airway's narrow. They could have had some kind of traumatic injury. They could have hit their head and their teeth are busted and they have pieces of teeth stuck in their trachea. So just be aware that there's all kinds of different things that can actually cause an obstruction. We just need to kind of look for the signs and symptoms and be prepared to treat whatever we find. Like it says, an infection, it could be croup, it could be epiglottitis, two pretty big, significant respiratory issues. Fever, congestion, cold. Ask those questions when we get there to their caregivers. Remember that croup is an infection in just below the vocal cords. And then we know epiglottitis is the infection of that epiglottis. If it's a foreign object, it could be lodged both upper airway or lower airway. They may still be able to breathe, but still have an obstruction. Or it could be completely closed off. It depends on what that object is. Again, that stridor sound, that high pitch sound when we breathe in can indicate a partial airway obstruction, which means we still have an avenue to breathe for them and give them that additional oxygen to keep them going. And then signs and symptoms, lower airway, we know wheezing, crackles, fluid. So just remember, wheezing is lower airway, stridor's upper airway. And if you're going to listen to breath sounds, both sides of the chest, kind of right there at the armpit. It's kind of where the skin is the thinnest. Then, like I said, with airway stuff, we want to be aggressive. If they have an obstruction, we need to be trying to figure it out right now. If they can cough it and clear it, fantastic. At the same time, we all took BLS class, CPR class. We know how to do Heimlich. We know how to do the back slaps, abdominal thrusts for each stage of life. That's kind of what this is going over. So as long as you paid attention in CPR class, whether you took it with us or whether you took it with somebody else, that is giving you the tools for if somebody has an airway obstruction. And again, we never want to do a blind finger sweep. If we can see it and pull it out, good. But we're not going to go digging in their mouth trying to find it, because we run the risk of pushing it farther down. Good old asthma. Okay, those bronchioles are inflamed. They start swelling up. There's mucus, blocks up the airway and prevents oxygen transmission. It can be a serious life threat if we don't figure it out quickly. Again, common causes, we know asthma can be induced by allergies. It can be induced by overexcitement, exercise, sports related. We know the signs and symptoms: wheezing, can't catch their breath, leaned over, increased respirations, increased heart rate. We've learned all these signs and symptoms. Treatment wise, oxygen. And we know that it's going to be, an albuterol, whether that's an inhaler, a nebulizer. We need to try and open their lungs up. So if they have their nebulizer, or their inhaler, we can assist them with it. Pneumonia, infection in the lungs, and one of the leading causes of death in children. Fever, difficulty breathing, wet lung sounds. Pneumonia is pretty bad in kids. We know it's bad in adults. Kids have a harder time with it. There's not much EMT-wise that we can do for that besides oxygen. But again, we need to get them transported to the hospital, let them confirm that they do indeed have pneumonia, get them started on antibiotics so that they can be treated for it. So again, that kind of goes into the respiratory distress, respiratory failure. Are they still breathing adequately enough that we can put them on a non-rebreather and they'll be okay for the transport? Or is it to a point where we need to actively be involved and start backing them? Croup, like we said, it's an infection of the airway underneath the vocal cords. It's a viral infection. Most times 6 months to 3 years old. You usually don't get it after that. You can see it a lot in daycares because it's easily passed between kids. If you hear that high-pitched sound when they're breathing, or if it sounds like a seal barking, it's very unique. heard it once or twice, that seal bark cough is pretty significant. With croup, we just kind of want to, for one, we don't want to agitate them. Okay? We don't want to make things worse where the rest of their airway is going to swell from agitation or trying to scream and holler. Humidified oxygen will do real well for these kids. It'll help kind of ease some of that irritation. And again, transport to the hospital. Epiglottitis, we said it's that infection of those soft tissues above the vocal cords. So where croup is below it, the epiglottitis is going to be above it. So just imagine, we've already talked about the epiglottis being significantly larger in kids, and now we're saying it's going to swell 2 to 3 times more. I mean, that can completely take up their entire airway. So a very significant problem. They'll complain of a sore throat. They'll have a high fever. That drooling is very significant. If you see that, it's serious. Again, same thing with these kids. Don't agitate them. Oxygen, transport to the hospital. Bronchiolitis, viral illnesses. Most time, kids get it from RSV. They just have a large amount of secretions with that. Secretions are easy. We can suction all that. But we need to be prepared for dehydration, fever, other problems that can cause shock. Again, treatment, oxygen, suction, transport to the hospital. Most of the time, this is going to be more common in males. And it's going to happen more often, like during the winter, early springtime. Good old pertussis, we talked about this a little bit during respiratory emergencies. Whooping cough. Kind of similar to a cold. Again, we just want to keep the airway open, give them oxygen if we need to. It is contagious, so just like if you've been on clinicals now, you should be wearing a mask pretty much everywhere. Ideally, you should be wearing eye protection as well, because it's spread through droplets, and droplets can get in through your eyes. So just be aware of that. Airway adjuncts, we kind of already know about these. Same thing we use for adults. And we've got the OPAs, the oropharyngeal that go in the mouth, and the nasopharyngeal NPAs that go in your nose. Depending on the situation, one may be better than the other. Obviously, if we think they have some kind of head trauma, we're not going to use an NPA. We're not going to want to put something up their nose and run the risk of pressing it into their brain if they had a skull fracture. So same kind of mentality that we use this stuff for adults. Don't necessarily use bite blocks. Bite blocks are really kind of associated with if we either intubate or put an eye gel. That little bite block keeps them from closing that airway off. And then bag valve mask, I think we all know how to use that. There you go, OPA. Again, if everybody remembers doing skills way back when we were actually allowed to all hang out with each other, we learned how to put those in together. Again, they should be on unconscious patients without a gag reflex, and those in respiratory failure if we're actively having to breathe for them. NPAs are usually the better way to go. They're more tolerated. Obviously, they don't cause a gag reflex, especially with responsive patients. We don't have to use them usually in people that are less than 1 year old because we can manage their airway without an adjunct. Like I said, if we think there's head trauma or some kind of obstruction in their nasal passages, we're not going to use an MPA. We don't want to risk any further damage. delivery devices. Got multiple different options for these kids, right? So blow by, we know if we, take an arm breather or nasal cannula and put it at 6 and just kind of let it blow near them or towards them, they're going to get more than that 21%. Again, nasal cannula 1 to 6 can go up to 44%. Non-rebreather is 95, and then the BVM is 100%. So it all just depends on the situation, what the patient looks like, what they can tolerate, or whether they're in distress or failure. Like I said, those right there, all the things besides a BVM are used for patients that can actually breathe, that have decent respirations. That BVM is for when we have to participate in their breathing. We've looked at them and said, okay, they're not breathing well enough. I need to help them breathe. Usually that's if it's less than 12, or if they're breathing like crazy and you can't even keep track of how many breaths a minute they're breathing. Most time, if you look at these kids and say, oh yeah, I need to breathe for them, that's what the BVM is for. Like I said, blow by, it's not the ideal. If it's all we can get, it's all we can get. But hopefully, we can use a nasal cannula or non-rebreather. Some kids will find it uncomfortable. It does tend to dry your nose out if it's on too high. Most of the time we can use a non-rebreather. Like I said, it delivers up to 90% oxygen. Fantastic tool. Always recommend oxygen. Again, BVM, that's when we're trying to actually help them breathe. We're doing some of the work for them. Whether they're unresponsive, whether they're breathing, like I said, less than 12 or faster than 60. Ideally, it would be nice to do 2-person ventilation if we can, but since children are so much smaller, if you remember in CPR class, we're able to provide a good seal with just one hand on the BVM. Just a couple pictures. Two rescuer, obviously ideal, especially if we're having to ventilate for the patient, because we get a better seal. We're able to put more of that oxygen into their lungs instead of some of it going out from a less than ideal seal. Like we talked about at the first part of this, cardiac arrest is most caused by respiratory failure. They tank fairly quick once they start running out of oxygen. So if you're looking at your patient and you notice that their heart rate is steadily going down, it goes from 120 to 100 to 95 to 70 to 60, you probably need to do something now respiratory wise, or they're going to stop. Good old shock. That's when our circulatory system can't maintain that stability. It's not getting enough oxygen-enriched blood to the organs. Eventually, this will cause cardiac arrest. It's not as fast as respiratory problems. But the main ones that are a problem in pediatrics, obviously trauma, hypovolemia, and that's also from dehydration, or they could possibly be septic from fever, being sick. So they do respond a little bit differently to fluid loss than we do. Like I said, they compensate really well for a long time, and then they don't. First thing that will probably happen is they're going to have that increased heart rate. They may start breathing faster, and then eventually they'll have that kind of cyanosis of the skin, either at the fingers, the nose, the mouth. But your first indicator is going to be that increased heart rate, increased respirations. Sometimes that may be the only thing you see right up until their blood pressure takes a big old nosedive into the 60s and they start becoming unresponsive. So be proactive. Again, ABCs, just like our regular assessment, unless we see some kind of obvious bleeding, then it changes to the CAB. So just remember, if you see some kind of obvious life threat, you address that first, and then you move on to everything else. And I can't hammer it home enough that kids will maintain until pretty much the very end, and then they will take a big old nosedive, and they will tank on you. Treatment-wise, simple interventions, oxygen, bandaging and splinting, things like that. We don't want to waste a whole lot of time. Okay, we want to treat the obvious life threats first, an airway, and then we need to get them going. Control their bleeding, oxygen transport. Fairly cut and dry. We want to keep these kids warm if we can, keep their circulation going. If they're conscious, if they're awake, put them in a position of comfort. Whatever makes them feel better. That way we're not causing additional pain. Because again, pain causes increased heart rate, puts more workload on the heart, pushes them kind of further into that shock state. And obviously, if it's bad enough, we're going to want ALS backup, right? Anaphylactic shock, we talked about this before, allergic reaction. Same thing as adults, okay? It causes vasodilation, airway constriction, can be deadly if we don't recognize it and treat it. How do we treat it? Well, epi, oxygen, transport. Bleeding disorders, same thing we talked about when we talked about bleeding disorders for adults. Hemophilia is a congenital condition. They won't have that clotting factor. They'll have to get factor VIII injections. Most of the time, it's us guys that get it. We're unlucky. Very, very severe. Any kind of small injury can cause a significant amount of bleeding for them. Because again, they can't clot. What can we do for these guys? Get them to the hospital as fast as we can. So there's your altered mental status mnemonic. It kind of helps you that AEIOU tips. Quite a few different things in there that you can think about for what's going to cause that problem. So when we're talking about mental status, make sure we know what the appropriate mental status is for that patient, for that age range. Okay. Seizures, we've talked about seizures a little bit before. Brain's going haywire. It's got that disorganized electrical activity. Infants, you may not even notice it. It may just be kind of, they make a sucking gesture, or they may kind of move their hands or the legs like a bicycle. That may be the only kind of outward sign you can catch if you're lucky. Obviously, when children get older, you may see it more significantly. They may have those muscle contractions. They may go into unresponsiveness in a postictal state. Just be aware that if they have a significant fever, there's always a possibility that they could have a seizure as well. There's numerous causes for it, all kinds. And if you notice there on the bottom, it says no cause can be found. So they may have a seizure and we may not be able to figure out why. That's okay. Again, we need to make sure we're assessing their airway, keeping their airway patent, ensuring that they have good oxygen, and getting them to the hospital. Like we said, it's not our job to completely diagnose and say, aha, this is why they had the seizure. No, we're going to let the doctors do that. The longer and harder these seizures go on, the longer it takes to correct. That being said, just like the other one, status epilepticus, things like that, if they continue or they don't stop for a long time, that's life-threatening, okay? We need to call for ALS backup or get them to the hospital immediately. Management-wise, like we've been saying, airway, breathing, circulation. We want to make sure their airway's open and patent, secured if we need to, and then we need to breathe for them if they're not breathing on their own. Meningitis, it's that inflammation of the tissue on the spinal cord and brain, the meninges. Being able to recognize if they have meningitis is probably important. At the same time, we can't completely 100% identify that, aha, this is meningitis. So just be aware if they have a stiff neck, if they're starting to have spots on them, might be thinking towards that meningitis diagnosis. There's a couple risk factors right there. Again, males, for some reason we are unlucky, get all the bad luck. Newborns, those with a crappy immune system, if they've already had a history of surgeries, head traumas, shunts, pins, foreign bodies. So a shunt, if any of you have never talked about one or seen one or heard of somebody who had one, a shunt can be placed in the brain, in the head, to divert some of that excess fluid to keep pressure off the brain. They may have like a VP shunt or an A. Excuse me, dang it. And signs and symptoms depend on the age of the patient. They may be able to tell you that they don't feel good, or you may just have to look at the patient if they're unresponsive. That bacteria causes that quick onset of it. It can lead to shock, and it can lead to death. So pinpoint cherry red spots or a purple and black rash, two of the most significant indicators for it. If you end up transporting somebody that has this, always kind of ask the hospital, hey, can we get some prophylactic care for it? That way you can be treated as well because it is contagious. So there's a little bit of a picture of that kind of cherry red spots. So if you see that on their skin all over, that should be your first indication, okay, this is probably meningitis. Again, standard precautions, which currently in this day and age should be pretty easy. We should be going in with masks and everything on as it is. Like I said, follow up with that hospital. That way, if they did truly have it, you can get the treatment as well. That way, in case you did contract it from them. And treatment-wise, managing symptoms, oxygen, breathing, transport to the hospital. So GI stuff, if they're having some kind of belly pain, we don't ever want to kind of dismiss it, okay? Abdominal pain is a pretty serious problem. There's a lot of stuff in our abdominal cavity that can be injured, that can be infected. So we need to take that seriously. Again, signs and symptoms of shock. What's the first two? Increased heart rate, increased respirations. Be on the lookout for it. It may just be from eating something. It may have been that they ate food that does not agree with them, or uncooked food. Same kind of thing when we talked about GI problems or stomach issues for adults. Most of the time, you're going to have them have nausea, vomiting, diarrhea. So again, with that, potential hypovolemia. Appendicitis can be common in kids. If they're having that pain on the right side, bottom, if they're guarding, be cautious with it. Kind of have that high index of suspicion. They need to go to the hospital and get evaluated. Again, history, taking, sample, OPQRST, all that stuff we get from the family or whatever caregiver is there will help us determine how serious this can be. You know, like I said before, how many wet diapers have they had today or in the last 2 days? Have they been able to keep fluids down? How many times have they thrown up? How many times have they had diarrhea? When they cry, are there actual tears present or are they dry? All good stuff to ask. Like we said before, kids explore with their mouths, so poisoning is unfortunately common. Common sources, you know, if they get into the cabinet underneath the sink and get into bleach, if they get into cleaners, if they get into grandma's pills that she left out, there's all kinds of stuff that they can get into. And again, just like when we have an overdose with anybody else, it depends on what the substance was, what their weight is, and what their age is. So don't discount if they're tired. They may not be tired necessarily. It may be a side effect from whatever medication they ingested. With kids, all it takes sometimes is one medication to be lethal. At the same time, unfortunately, we need to be kind of looking for signs of abuse. We'll get into that a little bit here in a minute, but just be aware. You know, if they're not answering questions right, if they're being kind of dodgy, if the family's being dodgy about it, that may kind of clue you in onto, okay, this isn't necessarily just an accident. And we're going to ask the caregiver the same things we would ask an adult. You know, what substance was it? How much did you take? What time did they take that, do you think? Have they had any significant changes? Did they choke? Did they cough? Did they throw some of it up? All stuff we need to know. And good old poison control. Poison control will be your best friend and stuff like this. Again, treatment's based on whatever the thing they ingested in is. Most of that will be done at the hospital. Our job, like always, is to maintain airway, oxygen, transport to the hospital. Dehydration, I'm sure all of us have been dehydrated at some point in our life. We know that that means we've got fluid loss that is worse than fluid intake. For kids, vomiting, diarrhea is going to be your number one and number two issues. If we don't correct it, if it goes on for too long, it can lead to hypovolemic shock and it can lead to death. Infants and small children are at a much higher risk because they're not able to necessarily control how much fluid intake they do get. With infants, you know, we can reverse that stuff fairly quickly in reality. Like I said, in a matter of hours, you know, they could be getting close to circling the drain and we treat them with fluid at the hospital, and they're fine. So just be aware of kind of what we're looking for. Again, asking those questions is always important. How many diapers have they soiled today? How many times have they peed? Are they trying to drink a lot? Are they not thirsty? How many times have they thrown up? Are they crying and having tears? Are they unresponsive? Are they responsive? Just be aware. Skin turgor, pull on their skin a little bit. If it tints real bad, you know, just like adults, it's kind of significant. That's an indicator of dehydration. Capillary refill is a good one too. Push down on their toes, the bottom of their foot, push down on their hand, see how long it takes for that color to return. So fevers, when we have that heat generation that's increased in our body, but we're not having any heat loss. Okay, most times this is from an infection. The fever itself is usually never life-threatening. It's the conditions that's causing it, like meningitis, that are the big problems. With these kids, we need to get a good temperature on them. Make sure we use the thermometer the correct way, whether that's if they're old enough to do it underneath the tongue, or if they're doing it underneath the armpit, or if all else fails, we can get a rectal temp. We just need to make sure it's accurate. With this, they may have all kinds of signs and symptoms. They may have difficulty breathing. They may have a rash, hot skin, stiff neck. The infants may have those bulging fontanelles on the top of their head. Their head may be bulging out a little bit. Again, treatment and transport, we're maintaining their airway, we're maintaining their breathing, and getting them to the hospital. So febrile seizures. These are specifically caused by fever. Most of the time it's going to be on the first day when they've had that fever. They'll have the shaking, and it's usually less than 15 minutes. This, especially with new parents, will freak them out. It may be signs of a serious problem. Like it may be the beginnings of meningitis. We don't know. Again, fevers are combating some kind of infection in the body. So we just need to be prepared that if parents say, well, he just started shaking 10 minutes ago and it just stopped. Okay. He's obviously had a febrile seizure. What else is going on? Again, we're going to do ABCs. We need to manage the airway, manage the patient themselves, transport to the hospital. Drownings, number one thing, your safety does come first. It's a lot more difficult when kids are involved, but we need to remember that we can't help them if we can't help ourselves. It is the second most common cause of unintentional death. Kids younger than 5 are the ones that have more trouble with it. With older kids, most of the time it's because they've, done something not smart, we'll say. Alcohol can be a factor, peer pressure, stuff like that. They could have jumped off something on a dare and hit their head. So, like it says, a few minutes without oxygen is going to significantly affect our heart, lungs, and brain. We need that oxygen. Hypothermia is going to happen once we're in cold water. Ideally, we used to go by the mentality of they're not dead until they're warm and dead. So if we have somebody that's been submerged in ice cold water in a lake or anything like that, we need to get them warm first before we, call it quits if they're in, cardiac arrest. Just be aware that diving injuries, always suspect that spinal cord injury, especially if they're unresponsive, especially if we don't know exactly what happened. Like I said, signs and symptoms depends on how long they were underneath. It could have been very short. They could just be coughing and have a little bit of fluid in their lungs, or they could be completely full of fluid, unresponsive, and in cardiac arrest. Management just depends on what you are seeing. Most of the time it's going to involve airway. We're going to need to secure the airway and ventilate the patient. Trauma is the number one killer of children in the United States. Okay? Our quality of care can impact their recovery. Again, this is because their body's still growing. Okay, their muscles and bones are still growing. They're fairly strong. Like it says, femur fractures are incredibly rare for kids because ideally it's the strongest bone in their body right now. But if it does break, that is a significant amount of blood loss. for kids. They can't handle necessarily as much. They'll maintain their blood pressure and they won't go into shock like we would, but it takes them less to start circling the drain, if that makes sense. There'll be a diagram of it here in a minute. And it's like it says, older children, adolescents, teenagers, they're prone to long bone fractures. Why? Number one thing, sports. They're running around, they're being active. And like it says, children are smaller than adults. Locations of injuries may be different. When we have an auto pedestrian accident and it involves a child, we're not going to think, okay, well, their legs got hit. Now it's going to be their shoulder and their head. I lost my train of thought there. Where am I? And again, like before, we know these kids' heads are huge. Okay. Most of the time, that's going to affect what kind of trauma we're going to expect. When they got that deceleration injuries, they're going to have more stress on the neck itself because it's carrying that big old melon more so than we are. Yeah, most of the time when they get hurt, it's because they made a mistake. Okay? They didn't have the experience and wisdom that adults do. So again, it's always important for us to understand those physical, psychological characteristics of kids. Vehicle collisions, they may run out there without looking. Okay, most of the time they don't pay attention to the whole wide world. They're focused on getting that ball back. So when they do get hit by vehicles, like I said, they're going to get hit kind of the head, spine, abdomen, up top versus where we would probably only get hit from the hips down. Sports injuries, they're involved in sports. East Texas is very sports heavy. We like our football. You'll see accidents and injuries all the time. Just remember, anytime we have those kind of injuries, we always need to take C-spine precautions to be on the safe side. And then you treat however you find the patient and what kind of symptoms and signs they have. Again, head injuries, like we said, their head is huge. They're top heavy. Their skull's thin. It's softer for the infants. So if they roll off the bed and strike their head, or if something hits them in the head, they have a higher risk of brain injury. Those scalp veins, they'll cause significant bleeding. We already know that our head is kind of a bleeder. Infants even more so. And nausea, vomiting, big time indicators for if they have a head injury. So they say, I hit my head, and then they start throwing up everywhere. So go ahead and put a check mark in the head injury box. Again, C-spine precautions. Our X collars work. If not, do what you can. Towel rolls, whatever we can do. Chest wall injuries, blunt trauma, V-car wrecks, getting hit with some kind of object. It does have the potential to produce that flail chest where we have that piece punctured out. So they may have that difficulty breathing, and you may see that paradoxical movement. Abdominal injuries are common. Think of when they're on a bike. If they hit something and go end over end on their bike, they hit their stomach on the handlebars. So those always present more difficult problems. Again, like we said, their liver, kidneys, spleen, all that stuff is closer together while they're still growing. And they run a higher risk of having significant injuries. Again, signs of shock, We know what those are. We want to try and prevent that hypothermia as well with blankets. Keep them warm. So there's your little picture. So if you look, it says signs of shock in adult, tachycardia, hypotension, and mental status changes. Signs of shock in kids, tachycardia, poor cap refill, and mental status. So it doesn't mention hypotension. Okay, we may not be able to see that, but that cap refill may start getting delayed to 4 seconds, 5 seconds. That's significant. Like I said, if you look there, it'll tell you about 80% or 20% blood loss for a kid is equivalent to 60% or 40% for us. So like I said, they don't maintain blood loss very well. Burns, we know they have more surface area than we do. They lose more fluid and they lose more heat. And again, their airway's narrow already. If they have some kind of inhalation injury, it's going to be that much worse for them. So we always want to be proactive with these and try to treat them fairly quickly. Most time it's exposure to a hot surface. They put their hand on the stove on accident. They could have pulled something down over them. They could have ingested something, that caustic substance. Again, same thing with adults. We worry about infection. They've lost that protective barrier with that skin. Now they're going to run the risk of higher infection rates. That being said, burn-wise, we also need to kind of take a look and see if we think it might be child abuse. There's a difference between having a splash injury burn from hot water from them stepping in the bathtub and having a straight line scald on their feet from being dipped in it. So obviously, if we see anything like that, we need to report it. Obviously, don't call the parents out or anything like that. We don't want to do anything to make things worse for the kid, but report something you think may be suspicious. We are required by law to do so. Again, severity, we know partial thickness, severe. If it's severe, partial thickness, it's 10% or less than 10% of the body. Moderate is 10 to 20. Severe is any kind of full thickness, third degree burns, or partial thickness more than 20%, or anything involving hands, feet, face, airway, or the genitalia. Okay, fairly similar to the adults. And again, they're managed the same way. Okay, we want to prevent infection. We want to cool them down and get them to the hospital. So extremities, we talked about growth plates a little bit earlier. Those are weak spots. So a green stick fracture, if you've ever taken like a healthy branch off a tree and you've broken it and you've seen how it breaks, but it bends a little bit beforehand, that's a green stick fracture. It's very hard to break a long bone on a kid. So if you have one of those kind of breaks, very, very significant injury. Obviously, probably a big mechanism of injury. Most of the time, they can be managed the same way as adults. If we obviously some kind of deformity, we need to splint it. Okay, same kind of treatment. Obviously, the first step for pain management is knowing, hey, they're in pain. They'll probably tell you, or you'll be able to see it. The Wong-Baker Faces scale, it goes from normal smiling to all the way to crying on a scale of 1 to 10. With most kids, that's going to be your best indicator, is using that scale. For us, EMT wise, most of the things we can do are positioning, giving them ice packs to reduce swelling, and elevating it. That's about it. They may need some kind of ALS intervention, pain management, depending on how significant it is. Besides that, we're going to talk to them nice. We're going to try and keep them calm, tell them we're there to help them. Okay? All right, disaster management. So whenever we have multiple casualty incidents, we usually use a triage system. Jumpstart is kind of the same system for children that are younger than 8, less than 100 pounds. Again, same thing as regular triage: green, yellow, red, black. Obviously, black is the worst. Green is the walking wounded, minor injuries. Okay. Obviously, infants are not going to walk. We know that. Yellows can be delayed. Those are the ones that are breathing on their own. They've got a good pulse, and they respond to some kind of stimulus, whether that's painful or verbal. So normally, if a patient is not breathing on an MCI, we leave them there, right? We black tag them, they're dead. With Jumpstart, we give these kids airway manipulation, we jaw thrust them, and we give them some rescue breathing. If they start breathing after that, then they're red. If not, then again, they're black tagged. So that's the significant difference between just triage and Jumpstart. A little bit hard to see there, but that's just the algorithm for it. Again, fairly cut and dry. Probably not a bad thing to have in your back pocket if you're not familiar with it. Again, an MCI is usually anything that your resources are overtaxed. So for us, most time, if it's like 3 or 4 patients that all need advanced level stuff, well, it's an MCI technically. Child abuse, neglect, obviously anything that would harm a pediatric patient. Physical, sexual, emotional, all that stuff is considered abuse. And if you notice down there, if it's not reported, it's likely to happen again. That's where we come in. If we see signs of this stuff, if we think something's going on, we have to report it, okay? Because if not, the next time it might not matter. So we'll be called for an injury to the child. It happens everywhere. It could happen in poor locations. It can happen in mansions. You know, it's universal. Just be aware of their surroundings. Document objectively. Don't make it personal in your documentation. As much as this is going to be difficult to do, we don't want to give our documentation a bias that can be thrown out in court. Because we do get called in to testify for this stuff. It does happen. But ask, is that injury typical for the child, for their age range? If they tell you, oh yeah, well they jumped off the bed and broke their leg and they're an infant, well, it's probably not correct. Is the caregiver being appropriate? Are they talking to you right? Or are they kind of being dodgy about it? Do they just want you to take the patient and go? Is there any alcohol use at the scene, drug use? Did they wait to call for help? Did they wait 2-3 days while this kid had a broken arm to get help? What is the patient respond to the caregiver? Are they attached to them, or are they just real distant? They don't really care that person's even there. All those are kind of things we need to be aware of when we're taking care of these kids. Multiple injuries, different stages of healing. Are they just playing outside and getting roughed up, or have they been beaten, last week and then 2 weeks before that? Just be aware of all that stuff. Okay. We have to be real kind of eagle-eyed with this stuff. Because sometimes we're going to be the only step that keeps these kids from getting killed eventually. Are they clean? Do they, are they healthy? Is there any bleeding from, rectal, vaginal, anything that could indicate sexual abuse? What's the home look like? Dirty wise, is it a lived in dirty, or is this just an absolutely filthy place that nobody cares about? Is it a crack house? Is it warm or cold in the appropriate temperature? Is there food in the house? Some of that stuff you may not be able to see openly, so we just need to be kind of head on a swivel, keep an eye out on your environment. So there's another mnemonic to help you. Child abuse. Again, this is stuff we were just talking about. It's things that once you see it, you kind of put it in the back of your head and say, okay, this might not be just a simple injury. Again, bruises, we're looking at color, location. Burns, usually if they're burns to the genitals, somebody else did it. Okay, most kids do not do that to themselves. Burns that look like a glove, they're inflicted by somebody else. They've got cigarette burns, grid patterns, branding, all that stuff should clue you in on this is something that somebody else did to them. Like I said, fractures the humerus or femur, they're long bones. They should not break very easily. They have to have major trauma. So if they're broken, they're not at a car wreck and they're at home and they say, oh, well, they just fell down the stairs, probably not the truth. Shaken baby syndrome, life-threatening. Destroys the blood vessels in the brain. They end up having brain bleeds. Some people will not openly tell us this kind of stuff. They won't tell us, well, I've been frustrated with the baby. He won't stop crying. But if you hear things like that, make sure to document. Neglect, do they have good clothes? Do they even have clothes on? Do they have shelter? Are they well kept? Do they take their medicine if they need to? Do they look like they're comfortable around these people? They also may be developmentally delayed because they don't get that interaction or stimulation. Like it says, they may be kind of hostile to you or afraid of you. If they don't want to tell you how they got hurt, well, what happened? How'd you hurt your hand? Oh, I don't know. I don't want to talk about it. Well, that's probably a red flag. That or the parent says they've had a bunch of accidents. They don't really care necessarily that their child is even hurt. And the abuser can be just about anybody. It can be somebody from outside the family. It can be the parent, just about anyone. Okay. Like I said, we are required by law to report this. Call the CPS hotline. Let them know. They will come and find out. They will get that kid help if they can. Sexual abuse, we talked about it last class. It can happen to any age person, any gender. Again, that assessment, we're limiting it. We're not examining things if we don't have to. We're going to treat bruises, fractures, bandaging, splinting, however we need to. Same thing as with an adult. Okay, we don't want them to wash. We don't want them to clean if we can avoid it. Caregiver of the same gender needs to be with the patient. Be professional, Get all the information you can. Any kid that you think is a victim or is a confirmed victim of sexual assault is transported. No ifs, ands, or buts. It's a crime. Like we already know that. Okay. Unfortunately, sometimes you will encounter sudden infant death. It does happen out there. It's not fun. Over the years, things have changed on how they think this happens or what can do to prevent it. Right now, they should be on their backs in on a firm mattress, no bumpers, no blankets, no toys. Should be in the same room as an adult, but we can't predict if this is going to happen. It just happens, hence the sudden part of it. There's a couple risk factors that they do talk about. Younger than 20, you smoked, low birth weight. Just be aware that, for one, we've got to assess the scene, make sure that nothing out of the ordinary happened. We do have to manage the patient. They are in cardiac arrest. As long as it's not been an extremely long time, we're going to work it. And then we need to support that family because this is now the most awful thing in their life. They will be blue or pale. They won't be responsive. They won't be breathing. They may have secretions out of their mouth. Just be aware of that. It's going to be the same kind of treatment cardiac arrest wise. We're going to do everything we can for them as long as we can. If they have those post-mortem changes, if they're having rigidity, if they have pooling of the blood, obviously it's been too long. We know that. Family may know that. They may not be able to come to grips with it. If you see those signs, you're going to call med control and confirm. If not, again, CPR, BVM, get them to the hospital. But just document anything you do or anything you see there. Okay. Because again, this may be investigated and our documentation becomes a record. So there's a couple things to consider: signs of illness, condition of the house, poor hygiene if it's there, what's the family acting like, or where the infant was actually discovered. Were they in their bed? Were they on the floor? Were they in the bathroom? All that is significant information. Again, this is the worst thing. Nobody wants to have a child die. Okay. They will be inconsolable. Okay. And it's not just hard on them, it's hard on us as well. Okay. None of us want to experience having a child die while we're trying to take care of them, let alone to come up on scene and see an infant dead that we know there's nothing we can do. Let the family grieve. Okay. They're going to go through those stages. We need to be there and be understanding and provide them emotional support. They may ask you to do something, even if, our protocols dictate otherwise. You can attempt to explain it to them. At the same time, remember your safety as well. But we want to introduce ourselves. We want to establish a connection with them. Okay. When we talk about them, for one, we don't want to talk about the cause of death. Okay. We don't know. They don't know. If we have suspicions, we don't want to talk about it right now. Ask them if they want to hold the child. If they want to say their goodbyes, let them have that closure. Use the kid's name. Communicate at eye level. And again, died, dead. We want to use those definitive terms. Passed away, gone, expired. They're not appropriate. We want them to know, just like we do, this is the end. This is definitive. There's nothing else. Okay. Don't make the mistake of saying, I know how you feel. For one, it can get you hit, but even if you have experienced that, we don't necessarily know how they feel because we're not that person. Okay, just be there for them. If they want you to call family members, call them. Don't give them long, elaborate instructions. Okay, here, I just want you to sit down here. Here, can you write their name for me, or can you tell me their date of birth? Keep it short. Again, wrap the kid in a blanket. Let them hold the kid. If we did do anything, if we put in an eye gel, if we put in a BVM or an OPA, if we had an IV on them, we put the AED pads on. Don't take them off. Okay? Because again, law enforcement may need to take pictures. So just remember that once this happens, our patient isn't necessarily just the child, it becomes the family as well. They may think it's their fault. We may have to talk to them about it and say, no, it's not your fault. Sometimes this happens. You just have to be careful what you say. Some services do arrange for visits afterwards. They can get them counseling and help with that process. But you have to have that specific training that unfortunately we do not offer at this time. And then for us, it's awful. It sucks. It's going to be difficult. Don't let it destroy you. Okay. Take a moment. Don't clear back in service right away. Talk to your partner. Talk to your team. Look for those stress indicators. Look for an increase in drinking or drug use or other factors. And if you see those, in yourself or others, consider getting help. All right, so apparent life-threatening event. It's those infants who aren't breathing, they're unresponsive. Sometimes they'll resume that breathing and get their color back with stimulation. Sometimes all it takes is rubbing them or just one breath, But classic ALTI is characterized by that change in muscle tone. They get real flaccid or they start choking and gagging. Again, they may be completely healthy, but if this happens, they have to go to the hospital. We need to get them evaluated. You need to maintain their airway, keep an eye on it the entire time. Again, a good primary and secondary assessment is going to help you out. Allow a caregiver to ride in the back of the ambulance with you. They have quite a bit of information. And again, we're managing the patient. We're not figuring out exactly what went wrong. That's the physician's job. Ooh, okay, finally, review. That's a lot. All right, so how does the pediatric anatomy differ from the adult anatomy?
D.
Yeah, they got that big old melon. Okay, their tongue's larger, their epiglottis is larger, it's floppier, their airway's narrow, all this kind of stuff. But their head is big and it causes problems. Right, so when a small child falls from a significant height, what strikes the ground first?
A.
Yeah, like we just talked about. Your head, that big old head makes them top heavy. It's gonna be the first thing that hits the ground. So you're assessing a conscious and alert 9-year-old child. You should do what?
B.
Yeah, we want to let them answer. Remember, they're learning how to talk. They're able to, or they know how to talk. I'm sorry. they understand kind of more complex questions. They can describe things to you. Let them be a part of that. Let them gain their trust that way. All right. Purpose of a shunt to do what?
B.
A. B.
So we talked about it real briefly, but hey, remember they've got that buildup of fluid in their brain. That shunt is going to divert that away and drain that fluid. That way they don't have pressure on the skull, which is going to cause pressure in the brain. Which of the following statements about febrile seizures is correct?
D.
D.
Yeah.
Oh, D.
Yep. Remember. So let's look back. They don't last more than 15 minutes. They're usually less than 15, and they don't have that postictal state. They kind of go into it and come out of it, and they're mentally appropriate for their age. All right, respond to a sick child late at night. He appears very ill, has a high fever, and is drooling, tripod position, and struggling to breathe. What should you suspect?
C, because he's drooling.
Yeah, like I said, that drooling is very significant. That epiglottis is now swollen 2 to 3 times larger than it already is. Make sure not to agitate these kids up. All right, treatment for a semi-conscious child who swallowed who knows how many pills. What does it include?
B.
B. B.
Yeah, we want to make sure we keep an eye on them throwing up. For one, that way if we can see any of the pills are in there. But we want to give them oxygen, get them to the hospital. We're not going to cause vomiting in any patient. That's just something we don't do. So when using the mnemonic child abuse to assess, the D stands for what? I was back on that little picture it showed us.
A.
A.
Yeah. So if they kind of don't really care and they say, oh well, this happened a couple days ago, it's not a big deal. It's definitely a red flag. All right, so we got a 4-year-old girl fell from the second story balcony, landed on her head. She's unresponsive, has slow, irregular breathing, has a large hematoma, and it's bleeding from her nose. You should. So here's 2 of the answers. Full body scan to detect other injuries, high flow oxygen and transport, put on a C collar, high flow O2, transport, stabilize her head, open her airway with a jaw thrust, insert an airway adjunct, assist ventilations, suction her airway, insert an NPA, apply a C collar and oxygen. Which one of those do you think?
B.
C.
Yeah, so make sure we look. Remember, she's got a head injury. She's unresponsive. We don't necessarily want to put an NPA in there. We want to put an OPA in her mouth We don't run the risk of having any kind of skull fracture, and we need to bag her. It's all part of the AEBC. All right, APU scale. What does the P stand for?
B. C.
C. C.
See, painful. So we're kind of flicking their feet, trying to get a response, or pinching them a little bit. The sternal rub for an adult, that painful stimulation. All right. There we go. All right. So we just went over pediatrics. Now we're going to go to the opposite end of the spectrum with geriatrics. Geriatrics are old people, 65 years or older. Okay, just like kids, they have special considerations that we need to think about. They're a little bit more difficult to assess. They have, again, illnesses, injuries that are not necessarily the same for us normal mid-range adults. So it's always a good idea to remember that these folks have been through a lot. For one, they made it through 65 years of being on good old planet Earth, and all that entails. Take your time with them. You need to be patient. For one, treat them with respect. Yes, sir. No, sir. Yes, ma'am. Mister. Don't call him, hey, Chuck, or hey, Mike. No, Mr. Jones, Mr. Van Winkle. Start with that. Let them tell you afterwards what they want to be called. And especially don't say, hey, how you doing, you old fart? Don't do ageism. Don't say, well, back when you were a kid, it was like this or anything like that. We don't want to be a jerk. Okay, we don't want to make them mad. We don't want to upset them to where now they won't give us information to help them, or they won't want to go. So again, speak respectfully. Identify yourself. They may not be looking for your name badge. Be aware how you present yourself. They are coming from a generation of hard work and respect. So be aware of that. Same time, speak slow. Don't talk fast. Okay, they may not be able to keep up. And all this depends on how they have progressed age-wise. Okay, especially if they've started developing dementia, if their hearing has worn out, if their eyesight is going. So that's all stuff that we need to consider when we're talking about geriatric patients. Only ask one question at a time and only one person. We don't want to give them stereo sound and have two different conversations going. They won't know what you're talking about. You'll overwhelm them. That being said, don't assume that they're all deaf. Don't immediately walk into the house yelling and screaming at them. They may tell you, geez, you're being too loud, shut up. Give them time to talk. Okay, they may have to collect their thoughts a little bit. Their engine's been running for way longer than ours. Okay, it may take a little bit more gas for them to get going. Actually listen to them. When they tell you something, repeat it back to them so that they know, yes, you did hear them. Don't talk about the patient in front of them, especially if you think they're hard of hearing. Don't say, this guy is an idiot for calling us for this. He may hear you, and now you've made him mad. Now he's not going to respond to you. Now he wants you out of the house, and then he later dies, and now you have a problem. And just like with kids, explain what you're going to do before you do it. It's a sign of respect. We want them to know, hey, I'm fixing to start an IV on you, or hey, I'm fixing to put this oxygen mask on you. It may be a little bit uncomfortable, but this is going to help you. Okay? So again, they have problems that we don't necessarily have while we are younger. Their bones are becoming brittle, things are wearing out, their balance is off, their walk is unsteady, they don't have as much strength. Hip fractures are common. For us to break a hip, usually it takes an extreme amount of force and some kind of significant trauma. For them, they could literally trip over their foot and fall on the ground. And this is usually due to some long-standing infection or osteoporosis. They're just having that weakening of those bones. They also like to sit. They don't get up a lot. Okay, they've moved around all their life. Now they're just taking it easy. So when they sit down, they potentially can get pneumonia, or they can have blood clots develop in their legs, which could lead to DVTs, or it could lead to a pulmonary embolism. There's some common conditions for you that older folks can be affected by. A lot of them we've discussed before. And then leading cause of death, obviously, number one is heart disease. Okay, they're having that atherosclerosis. Their veins and arteries are becoming thinner or narrower due to plaque buildup. So again, once we start aging, usually right at the early 30s, that's it. What you got's what you got. Now you're officially becoming old. Your cells don't regenerate near as well. Your decline in organ function, your kidneys start not working near as well. They're not working as hard. It's harder to breathe sometimes. Your heart has to work harder. So all this stuff starts decreasing, which puts them at an increased risk for illnesses. Like I said, airway musculature, their diaphragm doesn't work near as well. They can't expel as much air. So eventually they become barrel chested. They get that elasticity decrease in their alveoli. So now they're huge. They don't necessarily get as much gas exchange. They have to try and breathe harder. And then those chemoreceptors are slowing down. The more they slow down, the harder it is for them to respond to hypoxia the correct way. We talked about pneumonia before. It's an infection in the lungs, whether it's bacteria, viral, fungal. This is the leading cause of death for geriatrics. Mainly because a lot of times they're immune suppressed, whether they're taking medications, whether they're already on antibiotics anyway. They have a higher risk of getting pneumonia. Like we just talked about with sedentary lifestyle now, pulmonary embolisms are more likely to happen. Again, it's a blockage caused by a clot. Most presentation will be shortness of breath. They may have chest pain. They may appear purple from the chest up. It just depends. Sometimes all you may get is, well, I'm just a little short of breath. Treatment for these folks, oxygen, transport to the hospital immediately. And if something happens and they stop breathing, then you manage as appropriate. Heart-wise, hypertrophy, we know, is where it gets larger. It's been working for over 65 years. Okay. Those vessels and those veins and arteries are getting stiffer and stiffer and stiffer. So the heart's having to push harder and harder and harder trying to get that blood out. And over time, that causes the heart to enlarge, drops your cardiac output down, and then eventually causes hypertension because we're trying to force more blood through. So there's that picture of atherosclerosis, cholesterol, accumulation of fat. narrows those arteries down pretty significantly. Again, this can cause strokes, heart attacks, high blood pressure, all kinds of issues. They could have a aneurysm. Okay, we know an aneurysm is, a busted blood vessel. Okay, swells out and pops. Comes from high blood pressure. So we need to be aware of that. The vessels, the heart valves, they're getting stiffer again because of all that atherosclerosis buildup. We just need to be aware that that causes a significant amount of problems for these patients. And then like we said, our heart runs on an electrical system. Well, it's been working pretty well for, 65 years. Now the wiring's kind of gone bad. They may have an abnormal heart rhythm. They may have AFib or, increased sinus tachycardia. So just be aware that they may tell you, well, I have an irregular heartbeat. While that is a significant finding, that may be normal for them. Venous stasis, like I said, it's that change in lifestyle, that sedentary lifestyle. That blood may pool a little bit, especially if they've sat in the recliner for 3 days straight. They get that orthostatic hypotension, where when they stand up, their blood pressure drops. What this does is causes clots. Like I said, those DVTs, the deep vein thrombosis, or it can cause, again, a pulmonary embolism or a stroke. So just be aware if they tell you, man, I haven't done much in a long time. I just sit here on the couch all day. Probably a good thing to make a mental note of. Heart attack. Again, we know what a heart attack is. Whether it's a clot. These patients are going to be significantly more at risk. We need to be looking for, chest pain, shortness of breath, sense of impending doom can be associated as well. That being said, they may not always present with those symptoms. They may literally just tell you, well, I just didn't feel good today. And then we find out later that they had a massive heart attack. So always take whatever they're telling you is bothering them at face value, and that it's significant enough for you to get them evaluated. They called you, so we need to take that seriously. Heart failure, again, our heart's been working so hard for so long. Eventually we're going to have some kind of heart failure. Depending on which side of it is, depends on the signs and symptoms. Again, right-sided is where all that fluid ends up backing up into the rest of the body. So that's where we get that swelling in the feet, the pedal edema hitting, their fingers are swollen. And then the left side, that's where we back up into the lungs. That's where we get that phrase, the pink puffers, shortness of breath, difficulty breathing, sounds like fluid in their lungs. Paroxysmal nocturnal dyspnea, it's just a literal sudden attack of difficulty breathing at night. They may stop breathing for a second. It's not necessarily sleep apnea, but it causes them trouble breathing and they'll wake themselves up. Again, most of that's associated with COPD and CHF, your chronic obstructive pulmonary disease, congestive heart failure. Stroke has become the leading cause of death in older people. And stroke is where we have a blood clot or brain bleed up in the brain that causes a lack of oxygen. Preventable risk factors, obviously smoking, diabetes we can maintain with like diet, medication, hypertension, same thing, obesity, we can not eat near as much, get exercise. Things we can change. Uncontrollable factors, obviously age, race, and gender. We can't change those ones. Signs and symptoms of a stroke, we know it could be anything from slurred speech to facial droop, unable to use a certain side of the body, not making sense, not being able to talk correctly, gaze to the one side or the other. So all kinds of different signs and symptoms, and that's where we use our Cincinnati stroke scale, the FAST scale, things like that to determine if they are having a stroke. Good thing is hemorrhagic are less common, but they are more fatal. And that's where the brain bleed happens. Ischemic strokes, that's the blood clots. We need to know when this stuff happened. When were they last seen normal? That way we can identify it to the hospital and they can hopefully treat the patient, usually within 4.5 hours. Good thing is if it's a clot, technology is getting better and better. They're able to reverse some of that and pull the clots out using interventional radiology up to like 72 hours from when it happened. So again, we always want to know what time this happened or when they were last seen normal. Right there, like it says, candidate for stroke center therapy. TIAs, transient ischemic attack, mini strokes, could be the same signs and symptoms. Most of the time, once they start having those, it's only a matter of time until they have the big one. Change in the nervous system for older folks. Most of the time, it's changes in thinking, memory, slower response to questions, okay? They don't think as fast as we do. Your brain decreases in weight, so it shrinks down anywhere from 10 to 20%. So once it shrinks, the inside has shrunk, but the case around it hasn't. So there's now more empty space, which if they fall, if they have some kind of head injury, has more of a risk of having significant damage. And then most of the sensory organs decline. Their sight goes a little bit. Their sense of sensation, touch, pain tolerance goes up. They don't feel pain near as much anymore. Their hearing can go out. All kinds of different things. Okay, so vision, like we said, decreased visual acuity, depth perception. There's susceptibility to light. Cataracts. What cataracts is, we get that cloudiness in their eyes. They have to go get corrected. Decreased tear production. So if they get something in their eye, they may not be able to get it out. They may not be able to see up close. They may have to hold things out at a distance while you're talking to them. Glaucoma, macular degeneration, retinal detachment, all of those are significant things that affect the older generation. Hearing, a lot of time hearing goes. It's harder to hear those high frequency sounds. It does make our balance more difficult. Okay, those bones in our ear do help with balance. Presbyscusis, I think I said it right, is that gradual hearing loss. Slowly, eventually, we're not going to be able to hear. It just won't work anymore. Half the time, I don't hear very well anyway, as it is. So it just depends on how your body ages. Heredity. If you had, your father, your grandfather, or your mother, your grandmother had hearing problems, it's a likelihood that you will too. At the same time, we're all in a business where we hear a bunch of sirens all the time. that exposure to loud noises can affect that as well down the road. Taste, they don't have near as many taste buds anymore. They may not enjoy eating. They may just say, oh, well, I don't, it doesn't really taste good, so I'm just not going to eat anymore. So they may have a significant amount of weight loss. That sense of touch, that goes away. At the same time, touch can be involved with pain tolerance. So they may put their hand on the stove not thinking it's on, and it may take them a few minutes to realize that their hand is on fire, burning and melting. They may end up breaking their wrist and not realizing it because it doesn't hurt anymore. Those nerve fibers are gone for those nerves. They don't transmit that signal of, ow, this hurt. So dementia is something that becomes a challenge in older patients. It's pretty much irreversible. It's chronic. Eventually, it progresses into a loss of just about everything. Their social skills, their psychomotor skills, cognitive abilities. They don't remember who they are or who other people are. They're not able to operate things anymore. They can't cook for themselves. They have emotional outbursts. They don't respond appropriately. Potential causes, we're not necessarily sure sometimes. It's still being researched a lot. They do think that genetics does have something to do with it. Heredity, it's looking to be hereditary from some of the stuff they've found. Very debilitating disease. So some of the things they may experience, short-term, long-term memory loss, they may recognize that they had 3 children, but the son that's sitting there now, they don't recognize anymore. They may not pay attention to things near as much. Can't do the normal stuff they did anymore. Looking at some of that stuff, it's almost a reversion into a childlike state. They may not be able to tell you what hurts. They may not, they may not think that hitting somebody is a bad thing. Okay, they don't have that right or wrong judgment anymore. So delirium is, instead of dementia, delirium is just a sudden change. Okay, they have an altered mental status real quick. They can't focus, they don't think right, can't maintain attention. Happens about 15 to 50% of people that have been hospitalized once they're over 70. The good thing is most time it's something reversible, some physical ailment, metabolic problem. Most time with lab work and assessment at the hospital, they can figure it out, provide them the medication or treatment to fix it, and then they're okay. Our job, again, is just to assess the patient and manage them appropriately, signs and symptoms wise. Syncope. Syncope is fainting. Always assume it's life-threatening. Always assume something major caused them to pass out. Most time it's just an interruption of blood flow to the brain. Okay, they may have stood up too fast and they had that postural change and their blood pressure was not able to maintain that high enough blood pressure to keep cerebral perfusion. So then they just pass out until they can build their pressure back up. Neuropathy, peripheral nervous system, it's a disorder. They no longer have good sensation anymore. A lot of times it's affected by the feet and the hands. So be aware if they're having trouble with their hands, with their feet, ask them those questions. Hey, do you have neuropathy? And they may be able to tell you, well, yeah, I do. GI system wise, everything again is slowing down. They don't have near as much saliva anymore, so chewing, eating food can become difficult. They run a higher risk of aspiration or choking. Dental loss, they're losing teeth. Be aware that they may have dentures, so if you come across somebody who needs to be ventilated, make sure they don't have dentures and make sure they're out. Gastric secretion is your stomach acid. It's reduced down, which means your motility slows down, your ability to move that food through your digestive system, which causes stomach irritation, abdominal pain, blockages. They may end up with IBS. They may have cirrhosis of the liver from having fatty liver disease for years. All this stuff is associated with our body slowing down. So GI bleeding, always something significant, okay? Obviously, our GI system should not bleed in the first place. Most time for older folks, it's inflammation, infection, obstruction. Again, it could be just simply diverticulitis, like we talked about in GI problems earlier, last two classes. It could be irritation. It could be they have some kind of stomach virus. You could have peptic ulcer disease. Just be aware, signs and symptoms again are like other GI bleeds. They either bright red blood, dark tarry stool, abdominal pain, nausea, vomiting, increased heart rate. All that stuff are signs and symptoms of that. And it can be life-threatening if we don't get it treated at the hospital. There's a couple issues: gallbladder disease, if you still have one, bowel obstruction. Because with this, they take a lot of medications. We'll get into this in a minute. But the more medications you take, especially if they're pain meds, it may cause that ileus that we talked about before, the paralyzation of their intestines. They may not be able to pass stool anymore. Just be aware of all these kind of problems. And again, we're not trying to diagnose these. We're managing the symptoms. Ask them about NSAIDs, non-steroidal anti-inflammatory drugs. Number one, ibuprofen. That's the one everybody can remember. Ask them if they use those quite a bit. May kind of clue you in on they might have some kind of bleeding. Alcohol use, that orthostatic vital signs. So if we don't know what orthostatic vital signs are, it's, way back when we learned how to do blood pressures and take all those. When you're sitting down, take a blood pressure, and then you stand up and take a blood pressure. There's your orthostatic tilt test to see if there's anything different. That can help you decide if they are truly hypovolemic or not. So acute abdomen non-gastrointestinal complaints. They're hard to figure out. Okay. Most of the time, most serious threats are blood loss. And again, we talked about AAA before. It's incredibly fatal, rapidly so. So if you see something that is pulsating, again, we're not going to palpate it. We're going to transport them to the hospital. Right, renal system, same thing as everything else. It's all slowing down. Okay, we're not urinating near as much. We're not having enough blood flow in our tubal degeneration. We're running more risks of UTIs, kidney stones, infections in the kidneys. Okay, everything again is slowing down to the point where it's harder for it to work. And that decreased bladder capacity, well, they may not urinate quite a lot. They may end up urinating on accident. They may have to go more often. They may not go at all. And their that sphincter muscle control. That could be, they may have leakage. They may defecate on themselves. They may not know that they're doing it in the first place. They may start using the bathroom in the middle of the night. And then benign prostatic hypertrophy. Whoa, man, I can't say that. Enlarged prostate. Something to definitely be aware of. Incontinence is not normal for aging. Again, if they're urinating on themselves all the time, it leads to irritation, breakdown if they're not changing often enough, and UTIs. Urinary retention. When we talked about the kidneys in the first place, it can cause renal failure. They can have a buildup of that urine in the blood from the kidneys. The kidneys may just fail completely. So all this stuff is things to consider when we're talking about older folks. Endocrine system, their thyroid hormones change. With that, the thyroid controls quite a bit of stuff. Temperature regulation, weight control. You can be tired all the time now. Your heart rate may slow down. Your hair is not near as healthy. When we talk about diabetes, we talked about hypersmolar, hyperglycemic, non-ketotic syndrome. Okay, we talked about DKA as well, that diabetic ketoacidosis, and HHNS is a step above that. You know, it's normally 600 and above on that blood glucose level. Where diabetic ketoacidosis has those Kussmaul respirations where they're breathing real fast and real deep, HHNS will not have that. But the other signs and symptoms will be present. They could be unresponsive. They could be warm and to the touch. Immune system wise, their immune system's been working forever. It's now not as effective fighting off infections. Okay, they may have weight loss. They may have fatigue. They may be altered due to either pneumonia, UTIs, or any other infection. If you arrive on scene and see a patient is bed confined and they're altered, always kind of think of pneumonia and UTIs, two of the first things you should think of. That being said, their signs and symptoms, they may not be decreased or minimized. They may not be a big deal. Okay, their body they may have that systemic infection, but their body's not, I guess, up to date with it. Their heart rate hasn't increased significantly. The blood pressure hasn't gone down. They're compensating a little bit better. Bones start getting brittle. This one's more often in women post-menopause. They do break a little bit more easily once they are brittle. Their joints lose flexibility. We have a higher risk of having traumatic injuries involving fractures. They don't have near as much muscle mass either. They're not near as strong anymore, so if they do fall, they may not be able to get themselves back up. Or if something falls on them, they can't push it off. At the same time, they may eventually start getting shorter. Those discs start narrowing down, so they may end up 2 or 3 inches shorter than they originally were in their prime. Again, strength declines, ligaments, cartilage, they lose their elasticity. Makes it more difficult for them to move around. And osteoporosis, we know it decreases the bone mass. That's where these hip fractures, leg fractures, wrist fractures, all that stuff comes into play. is because they don't have near as much mass and strength in those bones like we do. Osteoarthritis, this affects your joints and destroys that cartilage. This is where bone spurs also develop. You get joint stiffness. When their joints get stiff, they don't walk normal anymore, right? They don't move the same way that we would. So they shuffle, so they don't have to move certain parts of their body. With shuffling comes the increased risk of tripping over something. Change in skin. That fatty layer underneath the skin is getting thinner. The elasticity of their skin declines. It's thin. It starts tearing more often. If you've ever seen a 85-year-old person when we try to pick them up or move them or they fall, that skin can be shredded pretty easy. Bruising happens more often. They have more vessels and capillaries closer to the skin. They don't have near as much protection anymore, so they're damaged. Their sweat glands don't work as much, so they get hot. Again, going back to the sedentary lifestyle, if they're sitting there all the time, they may develop those pressure ulcers. Cuts off that blood flow. Depending on how long they've been there, it can be significant to the point where it can destroy a lot of their body tissue. Main thing, what we want to do is if we're transporting patients like this, we always want to pad them. If they've got any kind of bony prominence, if their spine's sticking out kind of weird because they've been hunched over their whole life, or their tailbone is a little bit more prominent, pad that. We want to make them comfortable. So when we talk about toxicology for older folks, they are at an increased risk. One, we talked about it, their kidneys don't function as well anymore. They can't filter everything out. Their GI system does not filter near as well. It doesn't absorb quite right. And then their liver is not getting any kind of decent blood flow anymore like it used to. So it's harder and harder for their body to clean their own blood and get rid of that alcohol, get rid of those medications. So it stays in their system a little bit longer and is more effective. That's why majority of times when we give medications for geriatrics, we cut the dose in half. Like it says, most over-the-counters can have negative effects when they're mixed with anything else, especially with alcohol or other prescription meds. That's where polypharmacy comes from. It's multiple prescription medications for one patient. Negative effects, overdosing, negative medication interactions. Realistically, if you take 5 different medications, you have like a 50 or 60% chance of one of those medications interacting with the other. And then it just goes up like 10% for each medication after that. If you've seen these folks, most of them have their own small pharmacy in their bathroom. They have 8 or 9 medications. When we ask them, hey, what do you take this for? I don't know. My doctor tells me to take it. It may be all the information you get. That being said, they may not take medication in the first place because they can't afford it. They chose to have electricity or food instead of getting the meds they needed. Or they're not strong enough to open those childproof containers anymore. Or it could be that they can't see it. They're looking for the medication, but they can't find it anymore because they've got cataracts and glaucoma and problems that with their sight, they can't see anything. They may hear their doctor telling them, well, take this twice a day, and they hear something completely different because they're hard of hearing. Again, depression's a medical disease. It's not part of the aging process. It can be treated with therapy, medication. These people may be on their own. They may have no one left. Their family moved off and left them alone. They may be in a nursing home. It's lonely. They're alone. They get depressed. If it's not recognized or it's not treated, they do have a tendency to commit suicide. And most of the time, the risk factors are fairly obvious. Again, they're alone. They take a lot of medications, financial issues. All those are pretty significant factors. When they do it, especially men, they pick what's going to be lethal. They don't overdose on pills. They'll go take their pistol. They'll take it to their head. They don't care anymore what they look like afterwards. Common predisposing events and conditions, telling people, I'm sorry, I'll miss you. I had a good run, things like that. Same thing we kind of look for in regular adults. If you see that they have those signs and symptoms, that they're kind of presenting like they may be depressed, it's okay to ask, have you contemplated suicide before? It helps with treatment. It helps us get them help. Just be respectful about it. Gems, diamonds created to help you remember what's different about older patients. Okay. You got the geriatric patient. Consider that they're different. They're going to present atypically, not the same. Environmental assessments, again, like everything else, it gives you clues to their condition. You may find a bottle of insulin. You may find 3 bottles of alcohol that's been drank. You may see pictures of war veterans and see that maybe he has some survivor's guilt. All those are kind of clues to what we may encounter. Medical assessment, same thing that we've been doing, sample, OPQRST, primary assessment, secondary assessment, vital signs, and then social assessment. How well are they doing socially? Do they have communication with other people? Does somebody come in and help them with their daily activities? Do they have a care provider? Are they living completely on their own? Are they living on their own successfully? Can they cook for themselves? Or are they just simply eating, a piece of turkey every day or something like that? Those are all factors that we need to look at. Be aware of what services are available in the area, especially for these older folks. Case in point, like Alzheimer's Alliance, Tyler. They're able to go in and help these people if they need it. So assessing an older person is challenging. Again, communication issues. We're not usually on the same wavelength. Hearing, vision difficulties. They may not see you. They may not hear you very well. They may already be kind of demented. They may not answer things appropriately for us. They also may have a laundry list of medications and medical problems that they've had over the years. Or simply it could just be that they're under the effects of whatever medication they're taking. So all very difficult stuff to deal with. Scene size up, again, same thing we've been doing for everybody else. We're taking in the environment, looking around, starting with our dispatch information. Most of the time, old folks are either in their homes or they're in nursing homes or assisted living facilities. Okay? Most of them are not out, Friday nights partying hard at the bar. Most of them live by themselves. They've outlived their spouses. They've outlived family. it may be difficult for us to even get to them, especially if they don't walk very often or they can't walk at all. They may not be able to get to that door. We may have to find another access in or have somebody gain access for us. And we always need to kind of be on the lookout for unsafe conditions or something negative. If they don't have heat, if they don't have electricity, things like that. Because just like we have child protective services, we do have adult protective services that does the same thing. MOI, NOI. This may be difficult, just like with kids, they can't really tell us. Older people are the same thing. They may have altered mental status already or dementia. They may not be able to accurately tell us what happened. If somebody is there, ask them, well, why'd you call? Or why did the patient call? Did they tell you anything? Just be aware that some of the stuff that they have going on, diseases, medications, may cause this to be harder to determine. So primary assessment again, life threats first. Is there anything obvious? No? Okay. Decide if they're stable or if they're unstable, then work on our ABCs. Most time you should be able to tell this just by looking at them. Airway breathing, we're making sure that they're open and breathing adequately. Just be aware that suction might be necessary because they've lost some of that upper airway mechanisms. You know, coughing, gag reflex, those kind of go away eventually. So we may have to perform some suction on them. Circulation, poor peripherals is a serious issue. Okay, they might have that lower heart rate, and they may have AFib that is common. Again, like I said, our electrical system has been running all the time. We need to be aware that there may be some issues with it. They may have had some vascular issues. They may have had, hardening of the arteries, stiffening of the vessels. We may not be able to feel a pulse very well. When we check for their skin color and condition, their fingers may be ice cold from poor circulation. We may not be able to get a good pulse ox reading off of that. So be aware of those things. Transport decisions. Again, anything that compromises ABCs is load and go. Again, we're treating them to the best of our ability. We're treating the signs and symptoms, not trying to determine the cause. Unlike children, older folks are going to tank way easier. Okay? Again, their bodies wore out. Everything underneath the hood has been running for so long, it can't take much more stress on it. Again, history taking, same thing as before. We want to know a good patient history. We want to try and find all their medications. That way we don't miss something. And try to figure out early on whether this person is, if they're not alert, why are they not alert? Is this something normal for them, or is this something new that I can attribute to, diabetes or dementia or intoxication? Get you a sample history. Again, this patient may have dementia. We may not be able to get an accurate history from them. If we do get information, confirm it from the family. Hey, is this correct? And ideally, if we can, we want to take them to whatever hospital they usually go to. That way, that hospital has their medical information. They can determine a better treatment plan that way. Physical exams, older folks may not want you to expose them. Okay, they may be a little bit embarrassed. Again, like everybody else, we want to keep them modest. We want to try and maintain their privacy. That being said, their temperature regulation has gone out the window. They're not going to be able to stay warm most of the time. So be aware that you may have to, turn the heater on or give them a blanket pretty quick. Vital signs, heart rate may not necessarily be 60 all the time. It may be, 48, 52, especially if they're taking beta blockers. That affects the heart rate and slows it down a little bit. They may be in AFib, that irregular pulse that you feel, it's irregularly irregular, feels weird. That may be the normal heart rhythm for them. They may have had AFib for 15 years. Again, circulatory compromise, like we said, it kind of causes a problem with getting a good radial pulse. Well, we know where else we can get a pulse. Brachial, if we really wanted to, or go straight to the carotid. Again, doing your cap refill can help as well. So blood pressure tends to be higher, like we said. Our heart's been working extremely hard for a long time. It's trying to push more blood out. So it's going to raise that blood pressure. Cap refill, like I said, it is a factor. We can look at it, but with that decrease in circulation, it may not always be 100% accurate. So if we sit there and we press down on them and we get a 5-second delay, we need to double check and make sure that yes, that's accurate, or well, they have some circulatory problems. Don't just throw it out the window, but make sure we're taking in everything with it. That's why we have multiple different diagnostic tools and techniques. Respiratory rate should be within the same normal range. Sometimes they're just a little bit more labored. Like I said, they're having to pull more air in and they're having trouble getting it out. Always listen to the breath sounds. Like we said, pulse ox may not work sometimes due to circulation. So just make sure it's accurate if you're going to record it. Like everybody else, we're reassessing the geriatric patient, rechecking interventions, all that good stuff. 5 minutes for unstable, 15 for stable. Document absolutely everything. The history, the meds, the interventions, the assessments, all of it. It's all pertinent information for the patient and gives the hospital and the doctor a bigger picture of what we saw. So there's some assessment guidelines. Just kind of going over some of those. A lot of what we've already talked about. Some normal changes associated with aging create risk, complicate the assessment. Again, they don't compensate near as well. It's slow to do so. The risk of death and serious injury is far more increased in older patients. For one, their existing medical issues may complicate that. Because a lot of times when these folks have those irregular heartbeats, they end up on blood thinners. So if we have a traumatic injury and they're on blood thinners, it may make it worse for them. Again, physical findings might be a little harder to see. Healing takes longer. Again, their body's not working as well anymore. They're also more likely to have those life-threatening issues from being hit by a vehicle. Again, because their body does not heal, their body is brittle now. Their bones cannot take damage, and their organs are going to be that much more likely to be injured. Excuse me. Again, going back to that loss of sensation, dementia, neuropathy, all these folks run a higher risk of getting burned. Like I said, it's hot stovetop. They may touch it and not realize it for 5 minutes. Again, with this, that risk of mortality goes up because of all those medical problems they've had, or the fact that their immune system is now weakened after so many years of being effective. And we have to be careful with fluid replacement if we give anything, because again, those kidneys are weaker. They're not filtering out as much. They're not generating enough urine. We don't want to overload this patient unnecessarily. They do have a higher mortality rate from penetrating trauma. Again, it causes serious internal bleeding. Remember, everything's kind of weak. We don't have near as much stability in our body. Our skin is thinner, so any kind of penetrating injury may go farther than it would on a normal adult. Falls and bleeding cause fatal, non-fatal injuries to older adults. Again, their balance is off, they shuffle, and their bones are brittle. Like I said, it's nearly half of the falls result in traumatic brain injury. And we talked about their brain shrinks by up to 20%. They've now got a smaller item in a large case. So what happens when they fall? It rattles around. Again, all these changes make them more susceptible. Okay, they can't breathe near as well. Their blood vessels don't work as good. They're stiff. Their heart's having to pump harder. They can't feel anything. Neuropathy, brittle bones, their joints are stiff. All this makes them much more susceptible. And then, depending on their physical condition itself, if they're old, tiny, and frail, their body may not be able to handle, just a simple scuff on the leg. It may end up getting an infection from it not healing right. It's osteoporosis. We know that's the degeneration of the bones, makes them brittle. They run a risk of hip and pelvic fractures, which are very significant. Same thing with compression fracture of the spine. Okay. All those are more likely in older patients. Like we talked about, brain shrinks. Again, we might miss it because it looks like they just fell on the ground. Oh, well, they fell. They didn't hit anything, or they said they hit their head, but they're fine. They're alert. They're oriented. They're being normal. Well, meanwhile, their brain is slowly bleeding into that extra 20% space in there. So always err on the side of caution and assume there might be a brain injury on geriatric falls. Again, other factors predispose them to it. Again, blood thinners, alcohol, things like that. We talked about this a little bit. Their temperature regulation is shoddy at best. So they may be, I lost my train of thought again, hypovolemic from sweating so much. They may also be extremely cold because they can't handle the heat anymore. All this is affected due to decreased, their skin is thinner, the layer of fat underneath the skin is decreased, sensation is gone, and that decrease in the endocrine system up there with their thyroid destroys their temperature regulation even more. So like I said, trauma is never isolated to a single issue. With geriatrics, it may be that they had diabetic emergency before they crashed that car, or they were walking and all of a sudden they had a blood clot and they had a stroke and then they fell down and broke their arm. So I'll always assume that if they have trauma, that there's something else that possibly caused it. See the size up, we're looking for clues on the patients. Again, seeing if some kind of medical incident caused this issue. Primary assessment, or general impression, address the life threats, determine their priority, whether they're alert and oriented, whether that's normal mentation for them. Again, if family's there, hey, did they normally act like this? Again, if the patient's talking to you, we know the airway's open. Okay? If it's noisy, we know there might be some compromise in there. Again, older patients have lost that ability to cough very well. So there might be more secretions than we expected. We also need to look for dentures. And like I talked about, alcohol and blood thinners can make bleeding control a little bit more difficult. Again, older patients are going to go into shock a little bit more easily. Okay, their body cannot compensate near as long anymore. That being said, if they've had high blood pressure for years and years and years, and their blood pressure is normally 170 over 100, well, they could be going into shock with a blood pressure of 126 over 80. We just need to be aware of those factors. So again, investigate chief complaint. Chief complaint's what the patient talked about, what their problem is, as long as they are within their right mind. Physical exam, again, same way we do a physical exam for everybody else that's an adult. Just need to be looking for more trauma. So their breathing may be impaired. Again, they have that elasticity problem. The alveoli are all expanded, and they may not be getting enough oxygen in the first place. Get all your vital signs. Again, cap refill may be unreliable, depending on their circulation, but also that their heart rate may be a little bit lower if they're taking beta blockers. So reassessment, like this says, we probably need to reassess them more often than we normally would. Broken bones should be splinted. They happen a lot more often in older folks. Again, their bones are brittle. Like it says, that kyphosis on their back, if they've got a hunchback, if they're curved down, don't try to force these people into a normal position. Okay? Positions of comfort, pad the voids, make them comfortable. Hip pelvic fractures, we don't want to log roll them, especially onto the side that's hurting. But even when we do log roll them, a lot of times we have a tendency to pull on that hip area, and we don't want to further damage it. Again, keep them warm. We don't want to cause hypothermia. Most of them have temperature regulation issues anyway. And then provide them support. A lot of times these folks are going to be terrified to go to the hospital because they saw 3 of their friends go into the hospital, and guess what? They didn't come out. Lots of older folks, especially when you get into like the 70s, 80s, 90s range, associate the hospital with death. So we may need to comfort them and tell them, we're going to help get you taken care of, explain the process to them. And falls can be caused by anything, some kind of medical issue, could have a syncope, cardiac rhythm disturbance. They could have had their heart rate drop too low. We do need to find out why if we can. Look around the patient. Do they have 3 bottles of scotch laying around empty? Or do they have their insulin out and a used syringe there? All good information to kind of look for. Most of these calls, like it says, they're going to be at nursing homes. Old folks live at nursing homes or skilled care facilities. It's kind of hard to talk to these folks most of the time because they're altered anyway. Okay, they may not even know what the day of the week is or who the president is. When we do this, we need to ask the facility staff, hey, what's different about them today? What's going on? Why are you calling us today for this patient? And infection control, we've talked about quite a few of those before. Long story short, older folks, geriatrics, are more susceptible to all of these. Okay, they've had that immune system that does not respond as well anymore, so they're more likely to be exposed, or when they're exposed, they're more likely to catch something like C. diff. Most of these folks in the nursing homes are going to be on a buttload of antibiotics because everybody ends up sick and passing it around. Dying patients. Okay. So everybody has their God-given right to choose to die at home. Okay. These folks get palliative care, comfort care. With that said, if we're called out to these, we need to be understanding, sensitive. We need to figure out what the family wants to do. Hey, do you guys want them to go to the hospital? Do you want us to evaluate them? What's going on? And then we get into the advanced directives, these legally binding papers that dictate what kind of treatments can happen to a certain patient who cannot make these decisions on their own. Most of us are familiar with the do not resuscitate order. It allows us to withhold efforts in a cardiac arrest. What that doesn't say is it doesn't say do not treat. So if they're like actively choking, we still correct that. They're not dead yet. Okay? We can still pull that food out and treat them and let them go on living. It's only if we show up and all of a sudden they just die. Well, here's the paperwork. We're not going to do anything. Always err on the side of caution. If they haven't got you the paperwork yet, explain it to them. Okay, find me the paperwork. I have to start CPR, but give me the paperwork and I will stop. Just cover your rear. Just like child abuse, there is elder abuse. Again, this could be something where they take advantage of them. They're taking advantage of their emotional state, their property, or them themselves. Acts of commission, words, actions that cause harm. It's verbal, physical assault, sexual assault, or omission, which is failure to act. Okay, so that means not letting them eat right, or not getting them the appropriate medical care, not providing heat when needed, or cool air when needed. The downside is this is something that goes largely unnoticed. Most of these folks don't want to report it because they don't have anybody else to take care of them. That, or they think that something is going to happen. That person's going to find out and get them. They're not strong anymore. They can't handle somebody assaulting them. So they'll be quiet about it if it happens once, if it happens twice. Most of the time, older women, older than 75. A lot of times it's people that had trauma inflicted on them beforehand, just creating a perpetual cycle of it. But it can occur anywhere. It does happen in nursing homes. We've seen that in the news before. Just kind of keep your eye out for all those signs and symptoms and red flags. Again, when you ask a question and they're not honest with you, whether that's them or their caregiver, that sends up a red flag. Again, same thing with the kids. We just talked about the 2-year-old who jumped off the stairs or something like that. Unbelievable. Same thing with this. Oh, well, Miss Smith, drove her car the other day and hit something, and that's why she has a broken arm. But there's no car outside, and Miss Smith is in a wheelchair and can't use her legs. Be on the lookout for stuff like that. And a lot of the same things we discussed with child abuse, apathy against the patient's condition. They don't really care. The caregiver gets defensive about it. They don't allow the patient to talk at all so that they can control the conversation. They're at the hospital multiple times. They tell you, oh, well, I fall all the time. I'm clumsy. It may not be the case. Again, those unbelievable or very vague explanations of why the injury occurred or how it did. Psychosomatic complaints, chronic pain, without explanation, self-destructive behavior, they're not eating right, they're not sleeping right, depression, or a history of substance abuse and possible sexual abuse as well. All those are kind of factors we need to be aware of when we go assess these elderly patients. So there's a little table on the types of elderly abuse. Again, physical abuse, bruises are usually found on the butt, lower back, genitals, and the thighs, face, and ears. Usually what they can swing at. Pressure bruises caused by a hand, oval grab marks, pinch marks, handprints. Look for that on the ears and stuff like that. The human mouth is extremely dirty. So anytime somebody's bitten, it can cause a significant infection. So most of the time, they're bitten on the upper extremities, on the arms. Check signs for neglect. Obviously, if they're not well kept, if they look like they haven't showered in a month, their toes look like they're not being well kept, their fingernails are like 8 feet long, stuff like that. Poor dental hygiene, poor temperature regulation. It's 30 degrees outside in the winter, and they're out there in a t-shirt and shorts. Because caregiver said, "Oh, they'll be fine." That are a lack of reasonable amenities at home. They don't have food, they don't have water, clothing, things of that nature. Again, if you see any kind of injuries to the genitalia or rectum and nobody said anything about them and nobody said that they had any kind of trauma, always suspect sexual assault or abuse and report it. All right, review time. Least common cause of death in patients over 65 years of age is what? Least common.
D.
D.
Yeah, all the other ones are. Overdose isn't necessarily a leading cause. But heart attacks, diabetes, stroke, all that stuff is definitely killed them. All right. So according to the James Diamond, a person's activities of daily living are evaluated during which part?
B.
B.
Yeah. Yeah, it's that social assessment again. You know, how are they doing with daily activities, eating, dressing, going to the bathroom, getting washed? You know, if they're not doing it themselves, who is? Do they get all their medications on time? All that's associated with a social assessment. It's a condition that clouds the lens of the eye.
A.
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 You got that cataract. Okay. Nystagmus is that involuntary movement taken to the eyes. Stigmatism is just blurred vision. Glaucoma is that increased pressure. Dang it. Press button too fast. All right, called to a neatly well kept residence for an 80-year-old woman who lives by herself. She burned her hand on the stove. Got a full thickness burn. In treating this patient, it's important to note that but.
D.
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 Yeah, I got that low reflex delayed pain reaction. So increased risk of having burns. Slow onset, orientation, shortened attention span, and loss of cognitive function called what?
C.
C.
You'll see dementia. You 21-year-old man with a history of hypertension disease presents with tearing abdominal pain. He's got a blood pressure of 80/60, heart rate 120, his respiration 28. Assessment reveals that his abdomen is rigid and distended. Considering his medical history and his vital signs, what are you most suspicious for?
A.
A.
A. A.
Yeah. So remember that tearing sensation is pretty unique. And his blood pressure is already low. Abdomen is distended, so he's bleeding into it most likely. So there you go. Good job. Which the following is a physiologic change that occurs during the process of aging.
A.
C.
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 See, so their kidneys are have a decline. They have a decreased elasticity in the alveoli, but the alveoli themselves have increased in length. Like they're more expanded out, but they don't return back to normal, so they can't get as much oxygen exchange. Yeah, their kidney function doesn't work near as much. Right, so which of the following conditions makes the elderly patient prone to fractures from even minor trauma?
C.
B.
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 Yes, osteo means bone. Osteoporosis. What does polypharmacy mean? Patient who takes what?
A.
A.
Yeah, we got that. Polypharmacy. Poly means many. All right. So they take multiple medications every day, and the more they take, the more they risk some kind of negative reaction or side effect from all of that. All right. So inflicted bruises are commonly found in all the following areas except where?
D. D.
All right. Forearms. Everywhere else we can find them. Most of the time you don't find them in the forearms just 'cause they put them up to fight back. All right. Give me a second. Close that.